concept is not still ingrained in India, at least in uniformly rather. It is there in some parts, but it is not ingrained uniformly. Well, on paper, it is soothing that MMR has declined from 130 to 113 per 100,000 live births in 2016 and 18. That is SRS report by RGI, which is still lagging behind our Millennium Development Goal, which we ought to have been fulfilled during 2015 only, and it is still behind WHO standards set as SDG of 70. Maternal mortality and morbidity is a disaster. We as an anesthesiologist can contribute to the key part of solution in acute settings, in addition to the preventive obstetric measures taken by the obstetrician as well as the government. Especially, this is true not only in the rural setups like us, but also the small private nursing homes in the community in our area. The assured presence of an anesthesiologist during labor and delivery eases the situation a lot, rather sails through safely. Continuing in the same string, we have selected the topics of day-to-day occurrences, but crucial. We are fortunate to have a galaxy of national and international stalwarts to enlighten us. As I said, experts do not do anything different, but it makes a lot of difference listening and observing them to know how do they differ from us. Thank you very much.
Yes. Thank you, madam. So today's CME has been divided into 3 sessions, which will be moderated by excellent and experienced chairpersons. In the first session, we have esteemed faculties, Dr. Gauri Sankhe from UK, Dr. Radha Kunte from UK, and Dr. Mrinal Balki from Canada. This session will be chaired and moderated by renowned obstetric anesthesiologist and past president of ISA Nagpur City branch, Dr. Manisha Shembekar, along with Dr. Hemangi Abhyankar, senior consultant anesthesiologist from Nagpur. For those who have joined, kindly put your queries in the chat box, which will be taken by the chairpersons at the end of this session. I also request you to keep yourself muted to enjoy and learn from the talks by all our faculties. We have 2 other sessions by esteemed different faculties, which will be relayed after this session. With this, I hand over further proceedings to our chairpersons, Dr. Manisha Shembekar and Dr. Hemangi Abhyankar. Manisha, madam, please go ahead.
Thank you, Deepak. Hello, everyone. We begin with our first session, and I invite Dr. Gauri Sankhe for it. She will speak on general anesthesia in a parturient. General anesthesia in a C-section is really challenging for anesthesiologists because a parturient is a difficult airway, everybody knows. So let us see what Dr. Gauri has to say. So, can I have her CV, please? Thank you. Dr. Gauri has done MBBS from Mumbai and MD Anesthesia from University of Mumbai. She is a SAS Doctor Wellbeing Champion and at present at Royal Derby Hospital. I welcome Gauri. You can start your lecture. Dr. Gauri, you're there?
Yeah, I'm there, but I think I have already given my pre-recorded.
Her presentation will be played.
In Royal Derby Hospital at NHS. General anesthesia. So I'm going to talk about obstetric general anesthetic update and the present practice. General anesthesia was once the primary anesthetic technique used in obstetrics, both for vaginal deliveries and cesarean.
Sound is not very clear.
Of obstetric anesthesia has advanced. The use of general anesthetic has been largely replaced by new flexible techniques. It is currently estimated that about 6% of cesarean
Can we make it louder, please?
intubation. While general anesthetic is largely
Louder.
patients, it is the preferred mode of anesthesia in certain situations. Failed tracheal intubation and the risk of aspiration and the resulting aspiration pneumonitis has historically been the most dreaded complication of general anesthesia. We're going to focus on this few points. Is there really a problem? Is it really harder? Principles review, Obstetric Anesthesia Association and Difficult Therapy Society guidelines, and the training study, that is direct awareness of maternity patients. Obstetric anesthesia is going to get more and will be more complex. Maternal choice, age, IVF, all these are contributing factors. Much higher chances of all of us being involved with increase in obstetrical demands and expanding unit. Additional increase in general anesthesia cases for non-obstetric surgery, which I'm not going to touch it here, but we can discuss certainly. And currently, 1 to 2 pregnant women require general anesthesia, including non-obstetric surgeries as well. It's really harder to reach. Society guidelines have been published. Detailed guidelines of management of critical intubation in obstetrics have been developed. However, it
Pratibha, madam. Hello. Hello.
Hello.
Madam, the sound is not very clear.
Sound.
Yeah. So can we
Should
ask?
we start it again? Should we start
yeah.
again?
Yes, please. Or we have option of going live. Dr. Gauri is already there, no? So that will be better, I think.
Wait.
So I think we should start again. Again, we'll start one and see, sir.
Yes, please. Because the sound is not very clear. It's not very good. She can go live, madam.
Dr. Gauri, can you go live?
Yeah, I can go live. I just have to share my screen. Is that all
Yes,
right?
yes. Yeah. Please go ahead.
Yeah, please
Madam,
share.
you have to stop sharing screen from your side. Pratibha Deshmukh, madam.
Yeah. Okay.
Okay, is this volume all right?
Yes, absolutely.
I'll just share this, but host has disabled attendee screen sharing. It's written. So I can't share my slides though.
So host one more.
Make her co-host.
Yes, it's just that when I'm trying to share my screen, it's saying that host has disabled attendee screen sharing.
Just a minute.
Sure.
Yes, now please try.
Yeah, I'm able to do that. I'm just going to do that from my share. Okay, just now I need to. I'm just taking a minute for my file to be.
No issues. We'll wait.
Do you have my slides? I have shared with Pratibha madam.
No, unfortunately not. I do not have.
Okay. Slides of the
We have your slides. Should we put it from this side?
I thought that will be ideal because I can't find my slides because I'm not able to share my PowerPoint.
Ma'am, but the video will play along with it.
No, I have sent Pratibha madam. Should I just send it to you, my share screen, my PowerPoint to Deepak sir?
Yeah.
I'll just share with you my PowerPoint. I've sent you. Do you think you can play at your end? But I've sent on WhatsApp.
On WhatsApp?
Yeah.
Okay.
Yeah.
Let me check.
I'll also try from my end.
Okay.
Have you found any luck?
Yes, just a moment.
Sure. Okay.
I think someone is sharing the screen.
That's what I thought. It's at my end actually. I'm just trying to find what I
Okay,
sent.
I'll share from my end. No problem.
Okay.
You stop sharing.
Okay, I'll stop sharing then.
Have you found it?
Did you find it?
Yes.
Okay.
No, I think DMMC has
started.
Okay, please go ahead, ma'am.
Okay, so this is Gauri. I'm one of the anaesthetists working at Royal Derby Hospital in University of Derby Hospitals and Burton Hospital Foundation Trust at NHS. I've been an anaesthetist since 2002. I joined in University of Mumbai and finished my MD anesthesia in 2005. Of course, I'm not an expert. And this presentation was originally presented by Dr. Martin Treves and Dr. Gauri Sankhe in our divisional day meeting. And it has all the update on present and future obstetric anesthesia. Yeah. Can I forward my slides, please? Yeah. Can I forward my slides, please? Yeah. So my aims of the topic is there really problem? Is it really harder? Principal reviews, Obstetric Anaesthesia Association and Difficult Airway Society guidelines. And I'm going to touch base on DREAMY study, that is direct report awareness in maternity patients, which is really interesting study, which has been carried out only in England. Can I have the next slide, please? So obstetric anesthesia is going to get more and will be very complex because of maternal choice, age, IVF, and lots of other factors. Much higher chances of all of us being involved with increase in obstetric on-call demands and an expanding unit. Additional increase in general anesthesia cases for non-obstetric surgeries, which I'm not going to touch base here. We can, of course, because this is a topic of interest in altogether different discussion. Currently, 1 to 2% of pregnant women require general anesthetic or surgery in pregnancy. So general anesthesia was once the primary anesthetic technique used in obstetrics, both for vaginal deliveries and cesarean section. As the field of obstetric anesthesia has advanced, the use of general anesthesia has largely been replaced by regional techniques, that is neuroexcisional techniques. It is currently estimated that still 6% of cesarean sections still require general anesthetic and tracheal intubation. While general anesthesia is largely avoided in pregnant patients, it is the preferred mode of anesthesia in certain situations. Failed taken intubation, the risk of aspiration and resulting aspiration pneumonitis have historically been the most dreaded complications of general anesthetic, as we all aware of this anesthetic branch. Detailed guidelines for management of difficult intubation in obstetrics have been developed, which I said in an earlier slide, which we will be discussing bit at later stage. It remains important to remember that increased care should also be used when dealing with tracheal extubation and post-operative management. In the UK, there is EMBRACE study, which is confidential inquiry in maternal death reports have shown that a substantial reduction in mortality related to general anesthetic and airway management is achievable. However, they recommend frequent practice and assessment of the skills needed to manage difficult intubation in obstetrics. Aspiration of gastric contents have still been classified as a rare event, 2 in 10,000 general anesthetic, but identifying risk factors, for example, obesity and a known difficult airway or unanticipated difficult airway, and adequately preparing, that is fasting and decompression of the stomach before anesthesia in circumstances, are imperative in its prevention. Significant physiological changes we have to be considered. That's what they have been elaborated in this slide. How we go from
बोल वैष्णवी काय झालं?
Yeah. So physiological changes of pregnancy should be taken into account when considering anesthetics. Plan for pregnant patient. The most pertinent
फोन का केला तेच विचारते
are those changes involving respiratory, cardiovascular, and gastrointestinal.
अर्जंट काही नाही
Because of upward inflation of the diaphragm by the uterus and increase in transverse diameter of the thorax, functional residual capacity is reduced by 20% by term. This is all physiology we have gone through in our physiological medical first year of branch. Then minute ventilation is increased by 50%. The combination of decreased FRC and accounts for rapid uptake of inhalation of anesthetic agents. Increased maternal resting metabolic rate and increased metabolic demands of the feto-placental unit cause an increase in 60% of oxygen consumption. And that all leads to rapid oxygen desaturation of the pregnant patient during apnea and air obstruction. And in some examples, we touch base that mucosal infarction, laryngeal or pharyngeal edema contribute to the increased difficulty of tracheal intubation and excessive risk of bleeding. Mallampati scores have been found to worsen during pregnancy and can further change during labor. Cardiac output is increased by 50%, resulting in increased heart rate and stroke volume. The induction of anesthesia with intravenous anesthetic agents is faster. As we all are aware, the gravid uterus displaces the stomach in a cephalid position, which increases intragastric pressure and loss of the protective effects of the diaphragm on the lower esophageal sphincter tone. As the esophagus enters the thorax, progesterone also decreases the tone of the lower esophageal sphincter tone. It is common in pregnant women to have symptoms of acid reflux and regurgitation. So gastric emptying remains normal during pregnancy, but can be slowed by the onset of labor and parenteral and neuraxial opiates. The risk of aspiration should always be addressed for planning induction of general anesthetic in laboring parturients. Can we have the next slide, please? Yeah. So I'll come back to this. Exposing developing fetus to general anesthetic raises concerns about relationship between anesthetic agents and the risk of teratogenesis and future behavioral impairment. As I would like to say that Swedish birth registries compared more than 5,000 patients that had surgery during pregnancy. Half of them were under general anesthetic with controlled surgery. They reported no increase in stillbirths or congenital abnormalities. None of the currently used anesthetic agents. Can I have the next slide, please? Can I have the next slide, please? Can I have the next slide, please? Hello, can I have the next slide, please?
Pratibha madam, next slide please.
Okay, should I just continue then? Okay, so they reported no increase stillbirth or congenital abnormalities, Swedish birth registries. None of the currently used anesthetic agents such as propofol, opioids, neuromuscular blocking agents, and local anesthetic at standard concentrations have been shown to have teratogenic effects on the fetus at gestational age. Now, the recent publication of OAA and DAS, that is Difficult Airway Society guidelines, have shown the algorithm, which I would ideally like to show in my next slide, where routine use of So I have already discussed this. We do airway assessment. We have a standard WHO checklist. This is what we follow in Derby Hospital in liaison with our DAS guidelines and OA guidelines. So routine head-up position, we do use Oxford pillow for higher BMI patients or where we think there is anticipated difficult airway. And general anesthesia is recommended at improving airway manipulation and laryngoscopy in pregnant women with large breast. A combination of the following measure is recommended to prevent desaturation during we always give omeprazole. We used to give ranitidine, but we've changed our practice recently, and sodium citrate 30 mg patient, depending on whichever category patient is given as general anesthetic. This is my master algorithm or our master algorithm for obstetric general anesthesia scale critical intubation. I'll come there in a minute. So pre-oxygenation we always do here with tight fitting face mask for at least minimum 3 minutes to achieve end tidal oxygen level of 90%. Mask ventilation before intubation. Minimum of peak inspiratory airway pressure of 20 centimeter of water and applique oxygen cannula. Of course, there is no evidence base, but we can do 5 liter per minute. Non-obstetric patients with high flow humidified nasal oxygen up to 60 liter per minute may be used for pre-oxygenation, but mind you, this is non-obstetric patients. Recent work suggests that high flow humidified oxygen may not be as effective as pre-oxygenation with a face mask, but these studies did not investigate the advantage during apneic oxygenation in the setting. The use of, can I go back to the previous slide, please? This is the algorithm where we follow how we do. So the use of propofol for rapid sequence induction in obstetric anesthesia has several advantages, including familiarity, availability, and reduced incidence of drug errors, better suppression of airway refluxes when compared with thiopentol. The NAP5 study, which was carried out in 2014, found a high incidence of awareness during general anesthesia in obstetrics and in patients with unanticipated difficult airway. It is therefore recommended that additional doses of induction agent should always be available and be given if difficult airway is encountered. Now, if the first attempt at intubation fails, oxygenation should be either with face mask ventilation or high flow humidified nasal oxygen whilst we are communicating with the team, that is obstetric team, midwifery team, our ODP and anesthetist senior on call. The second attempt should be by more senior anesthetists present using a different laryngoscope. We have changed our practice. We are using video laryngoscopy these days. That is CMAC and glidoscope is available, but we prefer CMAC. Removal of cricoid pressure should always be considered, but of course that doesn't go without the risk. The recommended maximum number of attempts is 2. A third attempt should only be done rarely and by the most senior and the different anesthetists. Couple of things. Can I have the next slide, please? Yeah, so failed intubation, which I have talked. Airway swelling can develop very rapidly in a pregnant woman, and this can be quickly escalated to cannot intubate, cannot oxygenation situation, which is a dreadful situation, as we all must have gone through this situation at least once in our lifetime. If the attempt to oxygenate the woman fails and CICU scenario develops, it should be managed by surgical cricothyroidotomy. However, if cardiac arrest occurs before the baby is delivered, a perimortem cesarean section should be carried out and completed within 5 minutes of cardiac arrest. Major advances in obstetric anesthesia have resulted in improved maternal outcomes. Regional anesthesia, with its high safety profile, is the most common method of providing anesthesia to the parturian. However, a small percentage of women, general anesthesia is the only option. Therefore, it is essential to take into account the physiological changes of pregnancy and administer a safe general anesthesia, which minimizes the risks such as failed intubation, aspiration, and awareness. Can I have the next slide, please? So this is our protocol at the Difficult Airway Society guidelines in maternity patients, how we go about it. You can have a look. I have touched base most of the things in my talk. Can I have the next slide, please? So extubation carries the risk we have discussed as well. These are the guidelines. Sorry, can I have the next slide, please? Yeah, so extubation also carries the risk, which we have touched, and we always use our neuromuscular TOF monitoring when we reverse the patient from neuromuscular blocking agents, and always we prepare for reintubation. We have recently come across 2 eclamptic seizures patients where we have extubated them, but again, we had to reintubate them in view of worsening maternal condition. Can I have the next slide, please? So these are our guidelines in liaison with many societies for managing the airway patients with COVID-19. Again, because airway assessment is difficult, worsening Malampati score, difficult, a quick senior anesthetist has to be there, and PPE, it all makes it difficult. Can I have the next slide, please? So awareness. So this is a DREAMY study and bit of ACCA I'm going to cover. So general anesthetic and airway managed practice, we have had a prospective multi-center observational study. NAV5, it was in association with Royal College of Anesthesia and Association of Anesthetists, where accidental awareness during general anesthesia was discovered. This is a direct reporting of awareness in maternity patients, which was multi-center prospective cohort study that aimed to establish the incidence, risk factors, and the sequelae of AGWA in obstetric patients. As you can see that 1 in 20,000 of all anesthetists have hazard incidence, certain / probable. Neuromuscular blocking agents we have used, then the figures are 1 in 8,000, and without neuromuscular blocking agents, it's 1 in 135,000 patients. Considerable variation across techniques and subspecialties, but accidental awareness during cesarean section is in 1 in 670 patients. Of course, it all depends. Specifically, this study was aimed to examine the choice of drugs and airway management technique and evaluate of the change in the practice since NAV5, that is National Audit Project 5. Indications of general anesthesia, the training grade of most senior anesthetists present, time and duration of general anesthesia, and the anesthetic induction agents, that is rapid sequence induction if it is used. The pharmacological data has been included, that whether it's a thiopentol, it's a propofol, it's ketamine, or acetamidate, all 4 drugs have been used, of course, in varying range of patients, which I will be attaching the reference and the link for this study as well. Neuromuscular agents have been used as suxamethonium, rocuronium, and atracurium. And the reversal agent, depending upon whether we have used the sugammadex, if we have used rocuronium, depending upon the TOF, or if we are using neostigmine with glycopyrrolate. Data on airway management study included direct laryngoscopic view. despite having unanticipated or anticipated difficult airway, video laryngoscope has been rarely used, but we have changed our practice since a year and we have mobilized CMAC in our unit, and I'm sure most of the NHS trusts are heading in that direction. The primary airway device, difficulties in airway management and intubation technique were recorded in these studies, and the critical incidents like regurgitation, aspiration, and critical care admission were also studied. Difficult intubation was defined as clinical situation where the most senior anesthetist present required multiple more than 2 attempts, which I have touched base in my previous slides in Difficult Airway Society. Baseline characteristics included in this study, as you can see from this slide, is age of the patient, parity, ASA physical status, booking weight and height, and BMI. The surgical procedure was recorded as cesarean section, exploration under anesthesia, manual removal of placenta, or specified individual according to the procedure undertaken. Urgency of cesarean section was classified, as we all know, from Cat 1 to Cat 3. And if it is non-obstetric procedure, then immediate threat to the life, to the mother or baby, all those have been considered. But according to NCPOD, it's immediate, urgent, expedited, and elective. That is for non-C-section procedures we classified. Results were presented separately for cesarean section and non-cesarean section procedures for ease of comparison. Last few things to elaborate. All the data were collected in an online secure database. The main findings of this study are concerned about changes in the use of anesthetic agents. The traditional use of thiopental and dexamethasone for rapid sequence induction in obstetric anesthesia has been practiced in the UK or rather worldwide for longer than in many other countries. But propofol, to a lesser extent, rocuronium is being replaced as well. Dexamethasone has been replaced by rocuronium. In at least the practice is getting more standardized in our trust. A 2013 UK survey of consultant obstetric anesthetists have identified that thiopental was routinely used by 93% of respondents for induction of general anesthesia, but actually NAF5 study in 2014 suggested that 97% of obstetric general anesthetics still use thiopental. The persistence of thiopental use as an induction agent of choice in obstetrics was attributed to two main reasons. A belief of the use of thiopental was associated with reduced risk of accidental awareness and improved neonatal outcomes compared with other agents. A recent meta-analysis, can I have the next slide, please? Yeah. So a recent meta-analysis has shown that induction opioids, remifentanil and alfentanil in particularly, appear to be safe. We are using alfentanil, but we have the practice of using PCA remifentanil. Those who can't have neuraxial techniques like epidural or any other label analgesia, and then we can convert those patients into general anesthetic if they come under cesarean section or any other procedures, non-cesarean section. Research is needed to define the ideal dose and timing of opioids during general anesthesia for C-section. For that, a separate research will be required. The conduct of general anesthesia in obstetrics in England has changed since 2013. It's particularly the use of pharmacological preferences for induction of anesthesia and neuromuscular blockade. Longer lasting neuromuscular blockade were used more often for tracheal intubation in study than in NAP5 activity survey. There was no evidence for increase in use of neuromuscular reversal drugs and monitoring of neuromuscular drugs, both critical to minimize the risk of residual blockade and accidental awareness of general anesthesia. Can I have the next slide, please? Yeah, so this is the direct report study, which I was talking prospective. Sorry, the slides weren't moving. I'm really apologize for that. I will give you a few seconds to read this slide, and then I'll go get on with the next slide. So this study was in 72 out of 158 hospitals, maternity who deliver the obstetric patients care in England. Can I have the next slide, please? So inclusion criteria, as we have discussed, according to female ASA status and those who were exclusion criteria, which I'm happy to discuss later on. But if accidental awareness, how we follow if the patient has experienced that, and if there is any recall or any post-traumatic stress disorder or any postnatal depression has taken place, and how we follow up, that has been recorded as well. Can I have the next slide, please? Yeah, so 1 in 670 patients showed accidental awareness of during general anesthesia. Can I have the next slide, please? Yes, so we have, so this is the results with when we have used the neuromuscular agents, without neuromuscular agents, and how the accidental awareness, even at the induction and the emergence, that is 1 in 9 patients, those who have reported awareness. Can I have the next slide, please? So we always see the standardized psychological impact scores at 30 days were significantly higher in awareness patients than those without. 33% of 12 patients with accidental, which I have mentioned that they do develop post-traumatic stress disorder, plus minus postnatal depression. And accidental awareness during general anesthesia is a strong additional risk to childbirth for PTSD, and anxiety will always should be taken consideration, and patients should be debriefed accordingly. Next slide, please. The risk factors we have discussed. Can I have next slide, please? So the changes on horizon is that basically it was to find out the right induction agent, the right opiate. Of course, it will, and the if you are anticipating difficult or unanticipated difficult intubation, video laryngoscopy should be changes this on this horizon. Simulation practice we are carrying out quite a lot so that trainees can be trained if this situation arises, which is a good way of technique, though it's not live, but it's still we are simulating. Obstetric patient specific general anesthesia checklist we have got, which is a standardized form where we go through multidisciplinary team before the conduct of the anesthetic, and that is getting really popular. And changes to rapid sequence induction also is changing. At least we are bringing the changes. Can I have the next slide, please? Yeah, so this is the project of universal management of airway. I'm happy to share all these slides with you, and it's quite published on universalairway.org. And even perhaps to the point that video laryngoscopy should be the first line technique for all the obstetric general anesthetic. It may improve the safety. And can I have the next slide, please? Yeah. So I know it's been run through, but there are a couple of things I needed to touch base. I'm happy to attend the live question answer, and we can go through lots of questions and answers. Hopefully I'm able to attend that. Thank you so much. Deepak sir, I think I've finished.
Thanks a lot, Gauri. That was excellent. I think we'll go ahead with the other two lectures, and then we go for the question answers.
Sure.
Okay. So, can we have the CV of our next speaker, please? Next speaker is Dr. Radha Kunte, and her topic is PIH, bottling the demon and catching another, that is press. Dr. Radha Kunte is currently working as a consultant anesthetist at University Hospital of Leicester in East Midlands region of UK. In addition to obstetric anesthesia, teaching and simulation-based training remains her other passion. Her persistent goal in life is to strike a healthy work-life balance by indulging in hobbies like reading and traveling. Before moving to UK, she has worked as a registrar in Tata Memorial Hospital in Mumbai, which provided her with a great opportunity to manage patients with major cancers in addition to amazing intensive care exposure. Her qualifications are completion of clinical training certificate in anesthesia in UK in August 2020, final FRCA in June 16 and primary FRCA in January 14. DNP and anesthesia in November 20. So she very own shifted to UK. Can we have her lecture, please?
A very good afternoon to all of you. I am hoping that you are enjoying this webinar so far. My name is Radha Kunte. I'm one of the consultant anesthetists working in the UK in the University Hospitals of Leicester. I've been asked to speak on the ever-pressing topic of preeclampsia, its overview and how it's managed here in the UK. I've aptly labeled it as, can this demon ever be bottled? And hence, a likely appropriate picture at the start. So let's start. The learning objectives at the end of this presentation, I hope, will be ability to describe the diagnostic criteria of hypertension and preeclampsia, identify the risk factors, application of certain risk prediction models, and formulate a management plan for women presenting with hypertensive emergencies, and a small discussion regarding PRESS. Hypertensive disorders in pregnancy constitute one of the leading causes of maternal and perinatal mortality worldwide. In the UK itself, 2% of maternal deaths are contributed, or in the UK itself, 2% of the deaths are due to preeclampsia, and the rate is as high as 9% in developing countries like Africa and Asia. Globally, 2 to 8% of pregnancies get complicated because of preeclampsia. The maternal implications are usually high if the hypertension is left untreated, as these women are at risk of cardiovascular morbidity and stroke, and also have high chances of developing cardiovascular disorders in future life. The fetal implications are in the form of restricted growth, preterm birth, and in worst case scenario, death. Let's start our discussion by defining few things. According to the American College of Obstetricians and Gynecologists, hypertension in pregnancy is defined as systolic blood pressure of over 140 millimeters of mercury and diastolic blood pressure of over 90 millimeters of mercury, or both, ideally confirmed on 2 separate occasions, at least 4 hours apart, in previously normotensive women. Hypertension in pregnancy can be further broadly classified into the following subtypes: chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia superimposed with chronic hypertension. Chronic hypertension is defined as hypertension that presents before 20 weeks of gestation. The most likely causes are chronic ailments like essential hypertension or secondary causes like renal insufficiency. White coat hypertension is a subtype which is classified under chronic hypertension. 50% of these women tend to develop gestational hypertension or preeclampsia later in pregnancy. Gestational hypertension is defined as new onset hypertension that develops after 20 weeks of gestation, but without any features of preeclampsia. What is preeclampsia? A topic of discussion. So let's define it. The International Society for Study of Hypertension in Pregnancy defines preeclampsia as new onset hypertension accompanied by one or more of the following features at or after 20 weeks of gestation, and proteinuria or other maternal organ dysfunctions. Proteinuria is usually defined as or is considered positive if it's 1+ or more on a routine urine dipstick test. Nice. that is the National Institute for Health and Care Excellence in the UK, defines significant proteinuria on the basis of urine protein creatinine ratio. We also need to account for the fact that sometimes preeclampsia can present without proteinuria, but instead have one of the following features of maternal organ dysfunction, like acute kidney injury, liver involvement, neurological complications like seizures, severe headaches, blindness, hyperreflexia, hematological complications like thrombocytopenia and DIC, and signs of uterine dysfunction. So in nutshell, preeclampsia can be defined as new onset hypertension associated with proteinuria and or signs of maternal end organ dysfunction. Up till recently, preeclampsia has been classified as mild, moderate, and severe, depending upon the blood pressure at presentation and associated clinical features. Preeclampsia is an evolving clinical condition and hence can no more classified in terms of these severities. ACOG now recommends that preeclampsia should be classified only into two subtypes, with signs of severity and without signs of severity. The list on the left-hand side of my screen shows us an exhaustive list of severe clinical features, which are mainly the features I've just highlighted in the form of maternal end organ dysfunction. Sometimes severe preeclampsia can present in different forms, example being eclampsia or HELP. HELP is an acronym that stands for hemolysis, elevated liver enzymes, and low platelet count. It usually coexists with severe preeclampsia and has very high maternal and perinatal mortality. Women might sometimes present very critical unwell at presentation in association with placental disruption and DIC. Risk factors. Which women are likely to develop preeclampsia during pregnancy? There are certain high-risk factors and moderate risk factors. High-risk factors worthy of note are history of previous preeclampsia, BMI of more than 35, and association with chronic illnesses like type 1 and type 2 diabetes, chronic kidney disease, and essential hypertension. Certain moderate risk factors are primiparity, advanced maternal age, and family history of preeclampsia. Now that we have defined preeclampsia, talked about the risk factors, let's talk about how we assess this women. No blood test or risk prediction models can ever replace clinical assessment of at-risk women. Having said that, there are certain risk assessment models that are validated by NICE, which are useful in early diagnosis of preeclampsia and resulting and hence improve outcomes because of early diagnosis. There are certain placental biomarkers which are of interest, which levels of which are either high or low in cases of preeclampsia. Placental growth factor is one such placental biomarker, which normally peaks at 26 to 30 weeks of pregnancy and then comes back to normal at term. However, its value is reduced in women with preeclampsia. There is a multi-center study which shows that if placental growth factor values are low, around 20 weeks of gestation or between 20 to 35 weeks of gestation, then that woman can develop severe features of preeclampsia needing urgent delivery within 14 days. Hence, the test has high sensitivity and negative predictive value. The other biomarker of concern is tyrosine kinase, which is an antagonist of placental growth factor, hence causes vasoconstriction and endothelial damage. Understandably, the levels of it are quite high in preeclampsia. NICE now recommends that this placental biomarker assay, in addition to the standard clinical assessment, should be done to exclude preeclampsia between 20 and 35 weeks of gestation. Currently, these tests only have theoretical value and probably need more research and validation before they can be put into regular clinical practice, at least in the UK. NICE has validated certain risk prediction models which incorporate individual maternal risk factors, gestational age, vital signs, and biochemical observations, which help us identify at-risk women, identify the risks of the maternal adverse outcomes, and help in certain decision making. The current validated models in the UK are PrEP-S and full peers. Currently, their use into clinical practice is limited, but there's always a scope for increased use in future. Sadly, none of these risk assessment models can ever predict fetal outcomes. Pathophysiology. Pathophysiology of preeclampsia is complex and proposes various mechanisms. The two hallmark features seen in the pathophysiology of preeclampsia are defective placenta resulting into chronic placental insufficiency, which results into release of pro-inflammatory substances into the maternal circulation, causing the actual maternal syndrome. In normal circumstances, during implantation of placenta, the syncytial trophoblast invade the spiral arteries located in the uterine myometrium to form a fetal-maternal interface, which provides nutrition to the fetus. In cases of preeclampsia, due to defect in the remodeling of these spiral arteries, the invasion is poor, which results into defective placental invasion, which further results into reduction in placental blood flow and eventually results into chronically ischemic placenta. As clearly seen in this slide, the chronically ischemic placenta is going to release certain pro-inflammatory and angiogenic substances into the maternal circulation, which result into the eventual systemic vasoconstriction and endothelial dysfunction, which is hallmark feature of the entire, which is a hallmark of preeclampsia. This results into further end organ damage or maternal end organ dysfunction in the form of, which presents in the form of hypertension, microangiopathic injuries at the level of kidneys in the form of proteinuria, or at the level of liver, leading to periportal necrosis and elevated transaminases, and in the worst form, it might present as HELP. I feel this slide is quite self-explanatory regarding the entire pathophysiology. Preventive strategies. NICE now recommends that all women with high-risk factors should be provided with 75 to 150 milligrams of aspirin from 12 weeks of pregnancy to prevent preeclampsia. Women with more than one moderate risk factors are also offered aspirin from 12 weeks of gestation. Calcium supplements in a dose of more than 1 gram per day also lower chances of developing preeclampsia. Treatment options and optimal time of delivery. As clearly well understood in the pathophysiology, that the main cause or the main problem in preeclampsia is a poorly functioning placenta, which suffers from chronic ischemia. So the definitive treatment always remains delivery of the placenta. However, the timing of delivery is individual case based and is dependent on a lot of other factors like individual maternal risk factors, fetal lung maturity, and gestational age. The current treatment options available are expectant versus delivery options. Expectant management is usually offered to women with gestational hypertension and preeclampsia without features of severity up to 37 weeks of gestation. After 37 weeks of gestation, delivery usually should be conducted within next 24 to 48 hours. Expectant management is conservative management, which includes blood pressure monitoring and control, regular fetal assessments to assess fetal growth. Women presenting with severe preeclampsia or eclampsia should be delivered urgently, irrespective of age of gestation, once the maternal blood pressure is stabilized. Management. The main management of preeclampsia is medical. The goals being control of blood pressure and prevention of seizures. The aim of controlling blood pressure is to reduce neurological complications like intracerebral bleed and stroke. So any blood pressure or persistent blood pressure more than 140/90 needs medication. Currently, NICE recommends oral use of antihypertensives like labetalol and nifedipine. Methyl-dopa can be considered as a third line in women in whom labetalol and nifedipine is contraindicated. Prevention of seizures should also remain the cornerstone of treatment. Magnesium sulfate is usually used to treat and prevent seizures. The use is usually reserved for patients with severe preeclampsia and eclampsia. Hypertensive emergency. How do we actually medically manage a patient with severe hypertension? Let's start by defining it. ACOG defines severe hypertension as acute onset blood pressure of more than or equal to 160/110 millimeters of mercury, which persists for over 15 minutes. Any kind of hypertensive emergency is a medical emergency, and the aim is to stepwise and controlled reduce the blood pressure in order to avoid neurological sequelae like intracerebral bleed, stroke, and in few cases, myocardial infarction. Treatment should be instituted urgently in these women, usually in high dependency unit on a labor ward, preferably with invasive arterial monitoring. We are way past the use of oral medications in these cases. Hence, intravenous route of antihypertensives is often recommended. Depending on NICE recommendation and local institutional protocol, my trust uses the following drugs for treating hypertensive emergencies. Labetalol as an IV bolus or infusion, hydralazine again as an IV bolus and infusion. Care should be taken to administer fluid bolus prior to administering hydralazine. Oral nifedipine sustained release has a role and can be repeated every 4 to 6 hours. In addition to blood pressure control, care should be taken to maintain a strict fluid balance, restrict fluids to about 85 ml per hour in order to avoid fluid overloads on the background of leaky capillaries. Prevention of seizures also remains a cornerstone of treatment. Hence, magnesium sulfate should be started in the form of an infusion after the bolus. Fetal monitoring should be instituted in the form of continuous cardiotocography monitoring. If the women present before 34 weeks of gestation, fetal lung maturity should be achieved by administration of corticosteroids. However, delivery of the fetus should not be delayed for administration of corticosteroids once the maternal blood pressure is stabilized. Shared decision-making between the anesthetist and the obstetrician regarding the time of delivery should be made once the maternal blood pressure is stabilized. Eclampsia. Eclampsia is one of the severe forms of preeclampsia. Eclampsia is new onset seizures in women suffering from severe preeclampsia. They are often self-limiting. The chances of having a stroke following an eclamptic seizure is 10 times higher than in women with just severe preeclampsia or preeclampsia. The immediate management is often supported. That is, left lateral position, avoid further maternal injuries by instilling a bite block to avoid tongue injuries. Cornerstone of treatment to arrest and prevent further seizures is magnesium sulfate. Magnesium sulfate is usually given in a dose of 4 grams IV over 20 minutes, followed by an infusion of 1 gram per hour, lasting for 24 hours after delivery. Magnesium has a narrow therapeutic index, hence its levels need to be monitored whilst the women are on magnesium. Eclampsia in itself is not an indication for urgent delivery via C-section. Delivery should be planned in a timely fashion once mother's condition is stabilized and other factors are considered. HELP. HELP is again a severe form of preeclampsia, which can exist as a lone entity. As stated before, it is an acronym for hemolysis, elevated liver enzymes, and low platelet count. In absence of hemolysis, it is addressed as L. The clinical course of HELP is quite progressive and rapid and has high risks of maternal and perinatal mortality. On a background of severe maternal disease and non-reassuring fetal parameters, urgent delivery is indicated. Women suffering from HELP should be cared on an intensive care unit because they have high chances of developing pulmonary edema, ARDS, and renal failure. Close monitoring of blood tests, especially the liver function tests, full blood count, and clotting is imperative because the liver function tests and platelet count share an inverse relationship during the natural course of disease. Anesthetic considerations. Anesthetic considerations specific to preeclampsia are regarding the choice of anesthetic, that is regional versus general anesthesia. I think it doesn't need any debate, and hands down, regional anesthesia or analgesia is the most preferred technique for women with preeclampsia because of its added advantage of reduction in the systemic vascular resistance. It is well understood that preeclampsia affects platelets and it affects the clotting factors. Hence, monitoring these blood tests during labor is very important. Rather than, it is very difficult to define a safe limit of platelet count where regional anesthesia can be safely performed. Rather than an absolute number, I feel the trend of platelet count is more important to make that decision. ACOG now says that the lowest platelet count at which epidural or spinal can be safely performed is 70. But I personally feel that it should be individualized to a particular patient. Associated clotting abnormalities preclude the use of regional anesthesia. General anesthesia is often an option when regional anesthesia is contraindicated or there is no time to institute one. In addition to the routine risks of pregnant women undergoing a general anesthetic, preeclampsia offers or adds further layers of complexities like increased chances of difficult airway due to tissue edema and increased vascularity, raised systemic and cerebral pressures, which can result into neurological sequelae during crucial stages of general anesthesia, like intubation and extubation. Hence, care must be taken to blunt these laryngeal reflexes with drugs like esmolol, labetalol, remifentanil during intubation and extubation to avoid neurological sequelae. Irrespective of the type of anesthetic, the aim during the anesthesia or the aim during the cesarean delivery should be to maintain pre-induction blood pressure levels and to avoid reduction in the mean arterial pressure below 110 millimeters of mercury. In addition to blood pressure stabilization, care should be taken regarding fluid administration. Drugs such as ergometrin and non-steroidal should be avoided. Irrespective of the choice of anesthetic, magnesium sulfate infusion should be continued during cesarean delivery to avoid further seizures. Magnesium has anesthetic implications, especially under a general anesthetic, as it's known to potentiate the action of non-depolarizing muscle relaxant. It doesn't have any effect on succinylmetonium or sugammadex. Hence, if rocuronium is used, complete reversal with sugammadex can be achieved without any problems. Follow-up. Follow-up is very important as postpartum hypertension or delayed preeclampsia can present up to 6 to 8 weeks postpartum. So even if the women have had uneventful delivery, if they've had preeclampsia in pregnancy, they should have a follow-up in the next 6 to 8 weeks. Most of these women are at high chances of developing long-term cardiovascular complications or stroke and renal insufficiency. This means all these women should have lifelong follow-up with their general practitioners arranged. Let's put light on PRES. What is PRES? What is its association with preeclampsia and eclampsia? How is it managed? Let's answer these questions in a stepwise manner. PRES is nothing but posterior reversible encephalopathy syndrome. It's a transient clinical neurological entity which is characterized by certain signs and symptoms like hypertension, generalized seizure activity, headache, visual changes. It has characteristic neuroradiological images on CT and MRI and is more of a radiological diagnosis. Various causes of PRES include hypertensive encephalopathy, preeclampsia and eclampsia, renal failure, immunosuppressants, SLE, and so on. Preeclampsia and eclampsia are probably the most common causes of PRES. Exact incidence is difficult to know as neuroimaging is not routinely performed in this cohort. Patients usually present with neurological symptoms like headache, visual disturbances, blindness, and sometimes altered mental status due to development of cerebral edema and vasospasm of cerebral and retinal vessels. PRES almost always is reversible, but sometimes it can progress to irreversible ischemic damage, cerebral infarction, and even death. Treatment is similar on the lines of treating severe preeclampsia. However, neurological consultation is required at some stage and it is highly recommended. Diagnosis. PRES is mainly a neuroradiological diagnosis. MRI remains the cornerstone for diagnosis of PRES. The hallmark feature is bilateral symmetrical vasogenic edema in the territories of posterior cerebral circulation. The predominance of occipital lesions corresponds well to the neurological manifestations of temporary cortical blindness. This radiological picture is quite classic of the vasogenic edema seen secondary to PRES. PRES is usually reversible with prompt diagnosis and treatment. Effective management of the blood pressure associated with seizure, in addition to seizure prophylaxis, remains the mainstay of the treatment. If the women are antenatal, then once the patient is stabilized, delivery should be considered urgently. The patient needs to be informed that there is a measurable risk of preeclampsia and eclampsia in the postpartum period up to 6 weeks after delivery, even if they have had uneventful pregnancy and delivery. These are the references that I have used to base this presentation on. Thank you for now.
Thank you, Dr. Radha. Thank you for bottling this demo so well. We will have question and answers after all the sessions. This first session is over. So let us move to Dr. Mrinal's obstetric hemorrhage. Obstetric hemorrhage is the most frequent cause of maternal morbidity and mortality. And here the definitions are not useful. So meticulous clinical observation and high index of suspicion is required to control the obstetric hemorrhage and manage it well. Let us hear from Dr. Mrinal. May I have her CV? Dr. Mrinal is consultant anesthesiologist at Mount Sinai Hospital, Toronto, Canada. She is professor at Department of Anesthesiology and Pain Medicine, Department of Obstetrics Gynecology, and Department of Physiology at University of Toronto. She is senior clinical scientist at Toronto. She is the Fellowship Director, Clinical and Basic Science in Obstetric Anesthesia, and established a state-of-art lab at Mount Sinai Hospital for Myometrial Contractility Research. She is editorial board member of Canadian Journal of Anesthesia. To her honors and professional awards, she's got 51 awards in patient safety, research and education, excellence in research from Canadian Anaesthesiologists Society, Society for Obstetric Anesthesia and Perinatology, and University of Toronto. And she's been invited for 140 lectures and 105 publications to her CV. Research funding in Canadian Institute of Health Research, Ontario Ministry of Health, National and International Societies. And her areas of interest and expertise are spinal ultrasound, uterotonic agents, PPH, airway management, simulation, labor anesthesia, patient safety, and critical care in obstetrics. We can start our lecture.
Hello, everyone. Greetings from Toronto. First of all, I would like to congratulate Dr. Pratibha Deshmukh for this great initiative of setting up OB anesthesia in the new hospital and for organizing this CME. I wish her the best for this endeavor. And also thank you, Dr. Deshmukh, for inviting me for this talk. Today, I'll be talking about postpartum hemorrhage, mainly. And we know that women die from postpartum hemorrhage. Isn't it an irony that one life is lost while bringing another life into this world? Postpartum hemorrhage is a leading cause of maternal mortality and morbidity worldwide, and it occurs in about 5% of vaginal deliveries and 15% of cesarean deliveries. Mortality is about 25%. Worldwide, 127,000 women die every year, which is equivalent to one maternal death every 4 minutes. The morbidity is also quite high. It's about 20 million per year. In India, postpartum hemorrhage is responsible for about 20% of maternal deaths. 58% are due to lack of provision for emergency transport at community level. And there's a lot that can be done in the initial stages to prevent and effectively control postpartum hemorrhage. Postpartum hemorrhage mainly occurs because of uterine atony, which is seen in about 80% of cases. And other etiologies include tissue, trauma, and thrombin. So it can be easily remembered by mnemonics 4 Ts. Recent data suggests that PPH rates are increasing globally. And this increase is mainly because of increase in atonic postpartum hemorrhage. Why do we see this increase? Because of many reasons. C-section rates are increasing worldwide. If you look at Indian data, C-section rates in recent years have gone up, particularly in private facility. Also, rates of obesity, advanced age have gone up. Multiple pregnancy rates are up because of IVF pregnancies. And also there has been increase in rates of oxytocin augmented labor, all of which have contributed to global increase in PPH trend. There are several risk factors for uterine atony, which include intrinsic factors which prevent the muscle from contracting, and extrinsic factors as well. So these intrinsic factors include uterine overgestation, such as polyhydramnioles, multiple gestation, macrosomia, morbid obesity, uterine muscle exhaustion and relaxation as in long labors, high parity general anesthesia, intraamniotic infection, chorioamnionitis, prolonged rupture of membranes, and then extrinsic factors which prevent the muscle from contracting, such as functional anatomical distortion of uterus, as with fibroids, placenta previa, accreta, percreta, and uterine anomalies, etc. However, one has to remember that There could be many patients who develop PPH without any identifiable risk factors. And on the other hand, there may be women with risk factors who don't bleed. So it's quite unpredictable. So the treatment of postpartum hemorrhage, it's important for we diagnose this early and then follow basic principles of resuscitation ABC. There are different ways of managing, and these can be concurrently administered. We'll be focusing today on uterotonic drugs, and briefly we'll talk about some conservative surgical methods and radiological methods. So coming to pharmacological management of postpartum hemorrhage, we have first-line uterotonics, oxytocin, carbetocin, and second-line uterotonics, ergot, carboprost, and misoprostol. We also have tranexamic acid as an additional drug. Oxytocin is mainly given for labor induction and augmentation to facilitate vaginal delivery. It's also used for prevention and treatment of postpartum hemorrhage. Oxytocin binds with oxytocin receptors and increases intracellular calcium. It predominantly contracts the upper uterine segment. The onset of oxytocin is immediate. It's got a short half-life of 4 to 10 minutes. It's metabolized by enzyme oxytocinase. And therefore, it has to be administered as an infusion and can be titrated to effect. The side effects of oxytocin are dose dependent, and these include hypotension, arrhythmias, myocardial ischemia, water intoxication, pulmonary edema, convulsions, nausea, vomiting, flushing, headache, etc. The physiological effects of oxytocin depend on the number of oxytocin receptors and affinity of oxytocin with these receptors rather than plasma concentration. The distribution of these receptors is also quite variable. There are more receptors on the fundus and upper uterine segment than on lower uterine segment. So oftentimes you encounter a situation where fundus has contracted, but the lower uterine segment is still boggy. The receptors to oxytocin increase during pregnancy. They're maximum at term, and at labor, there's significant upregulation of these receptors. Myometrial sensitivity is also quite high to oxytocin at labor. So even if you give small amounts of oxytocin during labor, the uterus will show effective contractility. However, when you give too much oxytocin during labor, there's downregulation of these receptors, and this is called as desensitization. We validated this desensitization phenomena in our lab in vitro myometrial samples that were obtained from C-section patients. We found that oxytocin pre-treatment attenuates oxytocin-induced contractions in these settings. We exposed myometrial samples to low, medium, and high concentrations of oxytocin, and then challenged with additional oxytocin. We performed these dose response curves, and we found that when the samples were pre-exposed to high concentration of oxytocin, there was significant reduction in myometrial contractility when compared to low dose oxytocin pre-exposure or no oxytocin pre-exposure. Again, this can be related to clinical settings in oxytocin augmented labors when we give large amounts of oxytocin for prolonged periods, and then we give more oxytocin after delivery for uterine contraction. So we are likely to see poor responsiveness if the uterus is already desensitized with prior oxytocin exposure. Oxytocin during labor has been found to be shown to be an independent risk factor for postpartum hemorrhage. This case control study compared total dose, duration of oxytocin, and oxytocin infusion in women who had PPH secondary to atony versus control group, and they found that all of these were significantly higher in women with atony compared to the control group. So how much oxytocin should we be using at cesarean deliveries? We know higher doses are associated with side effects, so it's important we use minimal effective dose. So these studies again done at our hospital, we found that women undergoing elective cesarean deliveries require very small amounts of oxytocin for effective uterine contraction. However, laboring women who undergo intrapartum C-section require 8 times higher doses compared to these women. And this is again because of desensitization of receptors. Similarly, another study that used infusion of oxytocin, not boluses, but infusion right from the beginning, they found that laboring women require bigger doses as compared to non-laboring women. We also found that morbidly obese women require higher doses of oxytocin compared to non-laboring women. And if you look at the blood loss, it's higher in laboring women and morbidly obese women, almost double compared to elective section patients. So these are high-risk populations, and we need to be quite aggressive and vigilant while treating these patients for postpartum hemorrhage or uterine agony. Recently, international consensus statement was published on the use of uterotonics during C-section. They were published in Anesthesia in 2019, and I would strongly encourage you to review those. And these are the first guidelines that differentiate between elective and intrapartum C-section. The recommendation is to use 1 unit oxytocin bolus at elective C-section, followed by oxytocin infusion. Typically, we use 20 units in a liter and run 125 ml per hour. For intrapartum C-section, they recommend 3 units oxytocin to be given slowly and then run slightly higher infusion. Coming to carbetocin. Carbetocin is a synthetic oxytocin analog, which is available in several countries, including India. Now we have heat stable formulation, which remains stable for about 3 years at 30 degrees centigrade, and for about 6 months when temperature goes to 40 degrees centigrade. When compared to oxytocin, it has got a longer half-life of 40 minutes, which is 4 to 10 times longer than oxytocin. So we don't need to administer as an infusion. It can be given as a single shot bolus. It has similar oxytocin receptor affinity and is similarly affected by oxytocin receptor desensitization phenomena. So how much carbetocin should we be giving at cesarean deliveries? We found that at elective C-sections, you require small dose of carbetocin, about 15 micrograms, while women who require C-section during labor require higher doses of carbetocin, about 121 microgram. But one thing we realized is that women who require high doses of carbetocin are also at risk of developing side effects such as tachycardia and arrhythmias in addition to hypotension. So we do not recommend going above 100 micrograms in laboring patients. In morbid obese patients, again, we need a higher dose compared to non-laboring patients. Again, carbetocin follows exactly similar pattern as oxytocin, and we need to give higher doses in laboring patients and morbidly obese patients. What do consensus statement guidelines suggest? They recommend 100 units of carbetocin to be given slowly in elective section patients. You can use smaller doses of as low as 20 micrograms, and these are likely to be sufficient. So you can use the entire vial of 100 micrograms for 5 patients, and you can save cost by doing that. For intrapartum C-section, recommendation is to use 100 micrograms to be given slowly over 30 seconds, and we should not exceed 100 micrograms. So which drug is superior, carbetocin or oxytocin? This meta-analysis of 30 trials compared these two drugs, and they found that carbetocin reduced the need for additional uterotonics at cesarean delivery in women at risk of PPH, and also reduced the risk of postpartum blood transfusion when compared to oxytocin. But one has to remember that the studies included in this trial were quite heterogeneous in terms of routes of administration of these drugs and doses of these drugs that were used in the trials. This champion trial was published recently, which compared heat-stable carbetocin 100 micrograms intramuscularly versus 10 units of oxytocin intramuscularly for vaginal deliveries. This was a large double-blind randomized controlled trial in 10 countries and 23 centers. And they found that carbetocin was non-inferior to oxytocin for several outcomes, including blood loss, additional uterotonics, and adverse events, which implies that carbetocin is either equally effective or superior to oxytocin. Coming to second-line uterotonic agents, which include ergot, hemobate or carboprost, and misoprostol. Ergot exerts its uteronic effect by stimulation of alpha-adrenergic and serotonin receptors on myometrium. It also causes vascular constriction and cessation of bleeding. It's relatively contraindicated in pre-eclamptic patients because of the risk of hypertension associated with its use. Rapid bolus, IV bolus is not recommended, again, because of the risk of hypertension. Other side effects include coronary artery spasm, intracranial hemorrhage, nausea, and vomiting. It can be given intramuscularly or slow intravenously or even orally. Carboprost is 15-methyl-PGF2 alpha. It binds with prostaglandin receptors. It also increases oxytocin levels. It's relatively contraindicated in patients with reactive airway diseases because of the risk of bronchospasm associated with its use. Other side effects include nausea, vomiting, diarrhea, pulmonary hypertension, pyrexia, hypertension, flushing, and headache. There's no IV preparation available. It can be given intramuscular or intramyometrial. Misoprostol is another synthetic PGE1 analog, binds with prostaglandin receptors. It comes as tablet forms, 200 micrograms each. Can be given oral, sublingual, rectal, or vaginally, but sublingual route has the best bioavailability, but is associated with more side effects. And rectal route, although has slower onset, is associated with less side effects and is better tolerated. So that's the preferred route in our institution. Side effects include pyrexia, shivering, nausea, vomiting, and diarrhea. So which second-line neurotonic agent should be used first? Currently, there are no studies comparing these drugs, but this Maternal Fetal Medicine Units Network Caesarean Registry looked at hemorrhage-related morbidity with the use of second-line agents such as ergot versus carboprost. For morbidity, they looked at blood transfusion and surgical interventions, and they found that the morbidity was higher with carboprost compared to methyl ergonovine, which implies that ergot is most probably a superior agent compared to carboprost when it comes to using a second-line uterotonic agent. International consensus statement suggests ergot as second-line agent in the dose of 200 to 500 micrograms, either intramuscularly or slow IV. It can be repeated after 2 hours. Misoprostol, again, can be used via various routes. As we talked about earlier, it can be repeated after 15 minutes if required, and maximum dose to be administered is 800 micrograms. Carboprost can be given either intramuscularly or intramyometrially. You can repeat every 15 minutes to a maximum of 8 doses. And sulprostone is another drug which is not available in Canada. So we propose this rule of threes in the event of postpartum hemorrhage, which involves giving oxytocin 3 unit as an IV bolus over 30 seconds. Wait for 3 minutes. If the tone is inadequate, give additional 3 units of oxytocin, and then you have 3 other additional uterotonic agents that can be used concurrently. So ergot, carboprost, and misoprostol. Again, if the tone is inadequate after 3 minutes, you can repeat 3 units of oxytocin bolus. Remember, oxytocin is still the best drug, should be used as first-line agent, and then other uterotonics can be used if necessary. If the tone is adequate, you start oxytocin maintenance infusion. We find this rule of three is easy to remember and can be easily implemented in the setting of postpartum hemorrhage. Coming to tranexamic acid, this women trial that enrolled over 20,000 women with clinically diagnosed PPH from 193 hospitals and 21 countries. And they looked at the effect of early administration of tranexamic acid 1 gram IV on mortality, hysterectomy, and other morbidities. They found that their primary composite outcome measure of death from all causes or hysterectomy was actually not different between tranexamic and placebo group, but other outcomes such as death due to bleeding, death due to bleeding if given within 3 hours, and laparotomy for bleeding were significantly reduced in tranexamic group compared to placebo group. And interestingly, adverse events, including thromboembolic events, did not differ between tranexamic and placebo group, even though pregnancy is a procoagulant state. So it just reassures us that tranexamic acid is safe to give in pregnancy. Based on this study, WHO has recommended the use of tranexamic acid for postpartum hemorrhage. And they recommend early use of TXA within 3 hours of delivery. And they recommend that tranexamic acid should not be initiated if more than 3 hours have elapsed. It should be used in all cases of PPH, regardless of the causes, and it should be given as a fixed dose of 1 gram slowly over 10 minutes. And second dose can be given if bleeding continues after 30 minutes. Coming to conservative surgical and radiological methods, which include Bakri balloon catheter. So this catheter is more like Foley catheter, is inflated with about 500 ml of normal saline. It's left in uterine cavity and it allows the drainage of blood. It's usually kept in situ for about 12 to 24 hours. The success rate is 86%. Another method is B-Lynch compressive sutures. These are square sutures, which provide a tamponade effect and stop bleeding. The success rate is about 95%. And then other method is radiological method. If the patient is stable enough to go to radiology, bleeding vessels can be identified and embolized using gel foam slurry. Usually uterine arteries and internal iliac arteries are embolized. The success rate is about 87 to 95%. So just to wrap up some take-home messages, we know that oxytocin and carbetocin are the most effective uterotonic agents as sole drugs. Carbetocin may be superior to oxytocin. Both are affected by desensitization phenomena. So we need to consider dosing based on specific factors, BMI, comorbidities, and oxytocin augmentation. All these drugs have dose-dependent side effects, so consider judicious use. And second line uterotonic should be considered early, and we could consider surgical, conservative, and radiological methods in order to avoid hysterectomy. Thank you very much. I'll be happy to take any questions in the live session.
Thank you, Mrinal, for that excellent talk. I have some questions in the chat box as well. Let me have a look at them. This is for the first lecture. Dr. Gauri, are you there?
Yeah, I'm here. Yeah, thank you.
Dr. Shweta wants to know whether you can tell her something about induction exhalation interval to avoid awareness.
Yeah, so I would like to highlight there is a beautiful diagram in the nationalauditprojects.org.uk where they have elaborated that how, because every patient will be different, like some patients might be hypovolemic, some patients might be shocked. So if you're giving thiopental agent, and it has got the exponential decay as an induction agent. And when we start to titrate nitrous oxide and isoflurane or sevoflurane, whichever is in your setting, the gap, like there will be potential gap where that accidental awareness during general anesthesia can take place, that we need to avoid. So there's no as such fixed time, but we have to avoid that gap by getting high flows, that is overpressure. And then when we achieve the MAC at least of like 1% in sevoflurane with the use of nitrous oxide and oxygen, and 0.6% at least with isoflurane, again with nitrous oxide and oxygen, unless nitrous oxide is contraindicated. If you have the risk of pneumothorax or anything, then that's a different situation. But that mind the gap potential when there is a exponential decay from thiopentone and rise in volatile concentration, you have to be really careful of preventing accidental awareness. And I think I would just advise that there's no fixed time as such, but studies are going on, and that will be a different research. I'm sure there are many other faculties which can add on to this if they have any these things, but at least in my literature where I have studied, it will differ patient to patient.
Okay, Dr. Rita Gupta wants to know that if the patient is on magnesium sulfate, which neuromuscular agent should be used?
So I prefer to use for pre-eclampsia. Of course, magnesium sulfate can be given in two situations. It can be given in many other situations as well, but pre-eclamptic, eclamptic, or the maturity of the neonatal, if they are like in their less gestational age in their parturition. In that case, if magnesium sulfate infusion is going on along with the loading dose, we generally do it with rocuronium. And if there is category like not exceptional, except for one or two category, we tend to use TIBA with rocuronium with a reduced dose, but at the same time, it's 1.2 milligram per kg, averaging 70 kg weight, preparing Sugammadex to be kept ready if difficult airway is anticipated. So reduced dose definitely will be used. You can use suxamethonium as well, but again, like as we say that suxamethonium is good for 100 milligram for averaging 70 kg, and another pre-filled syringe should be kept ready for higher BMI patients. But then you have to take that call. I would use definitely reduced doses.
Would you use LMA as a routine for general?
Not as a routine, but if it is first failed intubation, then supraglottic airway devices can be used. Yes, and there are two patients in our studies where DREAMY study has been conducted from May 2017 to August 2018. They have used in two patients supra aortic, LMA or IGL, and they have got away with it. But I wouldn't use that routinely.
What do you use for post-op nausea, vomiting, and analgesic agents?
So we use as ondansetron and dexamethasone unless they are diabetic. Cyclizine can be the option. Prochlorperazine, Bacastem is the option. Omeprazole and sodium citrate we would have used prior to GA. And that is mostly as a prokinetic. And for pain relief option, sorry, is that analgesia, right? I'm covering. Yeah. So I would have used alfentanil. If patient is on PCA remifentanil prior to coming to GA, then I would be tempted to use remifentanil as an induction opiate. But alfentanil really serves a purpose in both the surgical incision as well as in the good neonatal outcome. And that's what the study has been going on. Again, it will require a different research. And second aspect, we give good morphine. TAB block is popular, or even quadratus lumborum block is also getting popular depending upon busyness of the unit. If time permits, you can do this block and they can do the wonder. PCA morphine is the choice. Unless they're allergic to morphine, fentanyl or pethidine also is the option.
Okay. And what would you do to minimize the hemodynamic response to laryngoscopy and intubation? Because we prefer not to give any opioids prior to the delivery of the baby.
Yeah, but that's what I said. Recent studies have shown that alfentanil and remifentanil are wonderful in minimizing the laryngoscopic response, as well as it goes really well with surgical response. And it has been studied, the APGAR scores, even on the neonatal outcome, it does not affect any post baby born, any oxygen requirements. So, and we always inform our pediatrician that alfentanil or remifentanil have been used, and the studies are very well documented. I can share the link as well. Or a good induction dose of thiopentol or propofol, unless they are hemodynamically compromised, and additional doses of propofol should be kept ready.
You still use thiopentol?
Yes, we do use. We have pre-filled syringes of 500 milligram of thiopentol ready, but practice is moving towards propofol. Some patients, 28 patients have been used ketamine as well, but that is because of hemodynamic instability. And etomidate have been used for 2 patients.
Thank you, Dr. Gauri.
Thank you.
Some questions for the next speaker.
Dr. Radha?
Yes. Hello.
Hi. Dr. Rita Gupta wants to know what is the cut-off BP and platelet count for giving spinal anesthesia, and what should be the INR, bleeding time, and clotting time? Are they also important for the neuraxial block?
Thanks a lot for that question, Rita. I think I was quite expecting that because it's a very standard question when people so, as I'd actually mentioned in my lecture, first I'll start probably with the blood pressure. I think there is again no set cutoff. The whole idea in case of preeclampsia is to have that stepwise and controlled reduction in blood pressure because the brain cannot quickly adapt. As we know, the cerebral perfusion pressure is completely dependent on the maternal mean arterial pressure, and the brain can't auto-regulate that quickly. So the whole principle of management of blood pressure should be stepwise and controlled drop. It's usually recommended that about 20 to 30% drop of pre-induction values is something that is acceptable. And in patients who have severe hypertension at offset, maybe a mean arterial pressure of about 100 to 110 is something that we should aim at in order to avoid those neurological sequelae that I was talking about. The second thing is about the platelet count. I was, again, it's a debate that is never ending. I think personally, if you ask me, trend of platelets is something that is extremely important. The rate at which they fall. What routinely happens in UK is that at presentation, if the woman's platelets are about 120, then probably having a coagulation profile is not something that we would normally do. A coagulation profile usually includes PT, APTT, and INR along with APTT ratio. Routine bleeding time and clotting time is something we do not do. But we also have to look at the other presenting features. Over the period of time, if the platelet count drops less than 100, we definitely 100 as in 1 lakh, we definitely that we should do some clotting tests. ACOG, as I had rightly said, has now said that the lowest platelet count at which a spinal or an epidural can be safely performed without the risk of epidural hematoma is about 70. But in our trust, or rather in UK, it's more about individualizing care to the patient. Look at the patient, look at the trend of platelets, and it's a judgment call you make, balancing the risk. Because giving a general anesthetic to a preeclamptic pregnant woman is not as straightforward as we would expect.
Okay, so that answers this question as well, the minimum platelet count for regional. What would you suggest for seizure prophylaxis? How much magnesium sulfate?
So routinely, I think seizure prophylaxis is recommended for women who have severe preeclampsia or who present with signs of the maternal organ dysfunction that I was talking about. I think more than actually aborting a seizure when it occurs, magnesium has more role for neuroprotection, and it prevents the further seizures by probably increasing lowering the threshold. So routinely, we give it in the dose of 4 grams IV bolus over 20 minutes. And it's definitely followed by an infusion given at a rate of 1 gram per hour for 24 hours post-delivery. So that is a routine practice. And a further 2 gram bolus can be given if the woman doesn't stop fitting for 20 minutes after she's had the initial bolus. So this is the routine seizure prophylaxis that we follow.
And would you monitor her clinically or by serum magnesium levels?
Routinely, it is clinically. So because it is one-on-one midwifery-led care that we have for such women. So I think the midwife looking after the women with severe preeclampsia will monitor the routine things, the respiratory rate, the deep tendon reflexes, and the urine output. And if there is any deviation from normal in these parameters, then we would send a routine magnesium levels. Otherwise, it's just clinically that we monitor them.
Coming to press, I think it's a terminology of a recent addition because of the radiological investigations that have been being done nowadays. So what anticonvulsant should be advised to these women?
It's a very interesting question, actually. Thanks for that question. I've myself been thinking because I think this week I have seen a very atypical presentation of press, which didn't fit into the exact definition. So as I've stated in my presentation, the commonest causes of press are preeclampsia and eclampsia. But sometimes there is an element of chronic hypertension in these women, which is not looked into. So it's very difficult. So usually if they present, antenatally, it's pretty straightforward. I think the management should be on the lines of severe preeclampsia, and it should be magnesium that should be used for seizure prophylaxis. But postpartum, it depends upon when they present. We say that delayed severe preeclampsia, I think that is a time where neurological consultation will help. Because though we think it is just preeclampsia, there could be other causes of, hypertension, like essential hypertension, all secondary causes. In those cases, I feel a neurological consultation is more important, whether, you need racetam, or whether you need drugs like nimodipine, which actually reverse the vasospasm and hence reduce the chances of seizure. So I would feel that a joint neurological consultation is more important, and the presentation of the patient is more important, whether it is antenatal or postnatal.
Thank you so much.
Thank you.
We move on to our last speaker, Mridal. Hello.
Hi, Manisha.
Nice.
Hello, everyone. Good morning, good afternoon, good evening.
3 times.
Dr. Dilip wants to know, Mridal, how much oxytocin bolus would you give? Although you have.
Yeah, if you were there for my presentation, we do recommend giving a small bolus. Usually for elective sections, we give about 1 unit of bolus and then we run an infusion. We typically put 20 units in a liter and run at a rate of 2.5, so 125 ml per hour. And for laboring patients, where we expect there would be more desensitization, we give 3 units as a bolus, and then we put the same amount, but we run slightly higher infusion rate, 250 ml per hour. Are you able to see me?
Yeah, we are able to see you, and we are able to hear you as well. 250
Okay.
Double the is it? Double the infusion.
Sorry, what did you say?
For non-laboring, for elective sections, you give 125 ml per hour, while in a laboring woman, you'll give 250 ml per hour.
No, 250.
Yeah, okay. So that is twice.
Yeah, so almost double.
Almost double, okay.
Yeah. Because we know these women, these are the women who bleed more, and these are the ones who are affected by desensitization. So you need higher dose of oxytocin in this patient population. So that's the reason we give it higher. Also in obese patients, like you expect, or any patient who is at high risk of bleeding, we typically go up on our infusion rate. So that's the main thing.
Dr. Parag Sable wants to know in how many cases you have noticed the clamping is done to prevent PPH?
We haven't done any in our institution. In last 15 years, I haven't seen any. Most of the times, like they would do uterine artery ligations, and that's enough, and they would go for hysterectomy. If the patient is stable, then we would go to radiology. And we have a lot of patients like placenta percreta. Those are the ones where we expect a lot of bleeding. And we used to, in the earlier days, we used to take them to radiology. We would put balloons in them, and we would inflate the balloons when there was any evidence of bleeding. But in the recent days, we have stopped doing that because the obstetricians are going for conservative. They are going for hysterectomy as opposed to conservative therapies. And also they have found there's not much difference because the radiological methods are associated with more complications. We have even had cardiac arrest in radiology suite. So having said that, most of the times they would go for, like, if they are not happy with conservative measures, such as say B-Lynch sutures or Bakri balloon, they would go for uterine artery ligations, iliac arteries ligations. And if that's not effective, they'll go for hysterectomy. So that's how they progress in their surgical methods. We haven't had to do,
Is tranexamic acid known to cause convulsions? Question by Rita Gupta.
It could, but it's a rare side effect of this drug. We haven't, at least we haven't seen in our population. And again, we have started using tranexamic acid more commonly in these patients since last 3-4 years. But I haven't seen any so far.
Carbetocin, how much bolus that you have mentioned in your talk, but have you shifted completely over to carbetocin rather than oxytocin?
No, not yet. Carbetocin is still being used for research purposes. One of the reasons is the cost. It's much more expensive. Many of the hospitals here in Canada have shifted to carbetocin in other provinces, actually, and most likely will be shifting as well. So for carbetocin, usually we start with ideally we should start, it's all based on the studies that we have done. The recommendation is to use 100 micrograms bolus dose to be given over 1 minute. And that's it. You don't have to run an infusion. And that's the advantage of giving carbetocin. But based on the studies that we have done, we think that you can get away with a smaller dose of carbetocin. The ED90 that we showed is only 20 micrograms. So you can start with 20 micrograms in elective section patients. And if you need more, you can certainly give higher doses, but not more than 100 micrograms. In intrapartum C-section, like laboring patients, we recommend you give 100 micrograms dose. Don't give ED90 dose, which is much higher than 100 micrograms because of the risk of tachycardias and hypotension. So one of the things that we have noticed is hypotension, which is same as oxytocin. Like regardless of what dose you give, like you give 20 micrograms or you give 100 micrograms, you would see the same amount of hypotension. So that's one of the limitations of carbetocin. So you have to be watchful for hypotension, monitor blood pressure, and give any vasopressors as necessary. But the advantage is you don't need an infusion. So that's the good thing.
Any other side effect like that of carboprost have you encountered with carbetocin?
No, main side effects are cardiovascular side effects. And most common is arrhythmia. Like in one of the studies that we did here, we had like some patients with bad, not just sinus, tachycardia or something. They had bigeminis. They had, one had VTAC to the point that we went and did angiography to that patient. She had ST elevations. We did troponins for all our patients after that particular case in the study. So I think cardiovascular side effects are more likely to happen if they have like any pre-existing arrhythmias, then you have to be careful. Again, we have limited information on this. We don't have any studies looking at carbetocin in specifically cardiac patients. But in general, we know that cardiovascular side effects are more or similar as oxytocin. Even oxytocin has the same side effects, but at least with oxytocin, they're dose dependent. You know that if you higher dose, you're likely to see more hypotension. But with carbetocin, they're not dose dependent. So that's what we're trying to figure out, like, what can we do to minimize these side effects that we see with carbetocin? But pretty much they would be same as oxytocin because they're binding with same receptors. They're working in the same manner. So you expect the same response.
Thank you. One more question. What will be the choice of uterotonics in PPH? Like first line, second line, what would you advise?
Yeah, so first line agent is always oxytocin. Like in our setting, we use oxytocin, or you could use carbetocin if you have carbetocin. And then second line is, so like I talked about the rule of threes, that's what is easy to remember. So we give 3 units of oxytocin, not effective. I would give another 3 units of oxytocin, 3 to 5, I would say, because if you look at the confidence interval, 5 units is the upper limit. So then when I'm using my second bolus of oxytocin, again, make sure you give your bolus really slowly. You start with additional uterotonics. You start with ergot. Ergot is my second line uterotonic. So I would give ergot, and my preference is to give it IV as opposed to intramuscular. because then it's more predictable. Intramuscular, women are so big, like I don't even know if they go intramuscularly, to be very frank. They are like morbid obese, and anyway. So intravenously, you give it diluted really slowly. So that's my second line agent. If the uterus is still boggy, then I would go for Hemabate or Carboprost. And then misoprostol, usually those are the tablets that you give. And I find the obstetricians and nurses are quite reluctant to give while the surgery is going on, because they have to go under the drapes and then insert those tablets in the rectum. So I prefer to give 1 or 2 tablets sublingual while this is happening, so that the effect kicks in. And then at the end of the case, they can put remaining tablets in the rectum. So usually, like, one of the questions that people ask is, how much oxytocin would you give? So I stop at 10 units of oxytocin. If I have maxed on like 10 units boluses, like small aliquots, and we put 40 units in a liter, give 250 ml, or just titrate to effect. That's it. Because if it's not working, then it's not working, because you have like set number of receptors, and once all receptors are occupied and it's not going to help anymore, and you have to move on to other line of uterotonic agents, and make sure you give tranexamic acid along with it.
And what about uterotonics in PIH? Dr. Umesh wants to know first line and second line uterotonics and status of Methargin, that is methylergometrin.
Methylergometrin. Yes. Thank you for that question. Again, oxytocin is the best agent we know. It shouldn't affect blood pressure. I mean, it would help in reducing blood pressure if it's high. Now, again, it's relative. Like, ergot is a relative contraindication. It's not an absolute contraindication in preeclampsia. If the patient is hypotensive, she is hypotensive. She's not hypertensive. So one of the main side effects that you see with ergot is hypertension. So preeclamptic patients might be more sensitive to the hypertensive effect as they are for any other vasopressor, because of more pressor substances in their blood. So you may see more hypertension in these women. So as long as you're watching blood pressure and titrating the drug, it's okay. It's a relative contraindication. But my second line agent would be, in this scenario, would be Hemabate, Carboprost, as opposed to ergot. But if we need ergot, you can give ergot, but just give a smaller dose, give titrated dose. And just be careful, because all the cases of intracranial hemorrhage that were reported in your UK confidential inquiry reports are when women were given symptometrin without checking their blood pressures. And they were already hypertensive, they were given these drugs, and they had strokes, intracranial hemorrhage. So just watch blood pressure. So that's the key, that monitor blood pressure and give these drugs. But certainly oxytocin is the first line agent, Carboprost is the second line, and then ergot could be third, again titrated to effect.
Thank you so much, Mrinal. Thank you, Dr. Gauri, Dr. Radha. Thanks for joining us. I, on behalf of ISA and DMMC, thank you all. We move on to the next.
Thank you for having us.
Thank you, ma'am.
Right.
So those were the excellent elaborative talks by all the faculties and very well moderated by chairpersons. As a token of honor and appreciation, we would like to present mementos to all our faculties. Dr. Anjali, can you share the mementos? Yes, Dr. Gauri Sankhe, Dr. Radha Kunte, and Dr. Mrinal Balki. Thank you all faculties. And for chairpersons too, Dr. Manisha Shembekar and Dr. Hemangi Abhyankar.
Thank you, Deepak. Thank you.
Thank you, ma'am. Excellently conducted. Thank you.
Am I audible?
Yeah. Thank you so much. Thank you so much. Just a minute, madam. As we all know that our CME has been granted MMC credit hours, and Dr. Narendra Thamne, senior anesthesiologist from Nagpur, is the MMC observer for today's program. We acknowledge his presence. Welcome, sir. And we will move on to the session 2 for today's CME. The next session, we have esteemed faculties, Dr. Ivan and Dr. Fabrico from Canada. And this session will be chaired and moderated by Dr. Archana Deshpande, Senior Consultant Anesthesiologist and Pain Physician from Nagpur, and Dr. Deepali Mandlik, Senior Pediatric Anesthesiologist from Nagpur. Before we go ahead, I would again request all the participants to please keep themselves muted all throughout the session. Over to you, Dr. Mandlik, madam.
Okay, thank you, Deepak. So is my screen being shared? Or
No,
should I share
not
it?
yet. Not yet.
Okay, okay. Okay. Okay, so good evening, everyone. Am I audible and visible also?
Yes, yes, you are.
Okay, okay. So good evening, everyone, or rather I should say good evening, good morning, and good afternoon, everyone. I welcome you all to this session 2 of this CME. First of all, thank you organizers for inviting us to chair this session. Pain relief in labor is an important aspect of modern obstetric anesthesia. The past decade has seen availability of many new and safe drugs like local anesthetics, short-acting opioids, and patient-control devices, etc., and many more. The coming of ultrasound has revolutionized obstetric regional anesthesia. To discuss this and much more, we have with us 2 esteemed faculties from Canada, Dr. Ivan Wild and Dr. Fabricio. We will first begin with the first talk by Dr. Ivan Wild. His topic is best and current practices in labor analgesia. Can you please share his CV? I'm unable to see actually.
Ma'am, can you please stop sharing the screen, then we'll share from this.
Okay, okay.
Yes, ma'am.
Yeah. Okay. So, Dr. Ivan, this is not clear, I think. Can you make it more clear? Dr. Ivan Wild has done his graduation from the University of Nottingham, UK. He did his anesthesia training from University Hospital, Oxford University, UK. He did his advanced obstetric anesthesia fellowship from Mount Sinai Hospital, Toronto. And currently, he is a lecturer in Department of Anesthesia and Pain Medicine, University of Toronto. Welcome, Dr. Ivan Wild. Kindly show his presentation.
Hi, hello. My name is Dr. Evan Wild. Thank you very much to everyone in Nagpur, India, and Dr. Deshmukh for inviting me to this conference today. I am a staff anesthesiologist. I believe you call them consultant anaesthetists here at Mount Sinai Hospital in Toronto, and I'm also a lecturer with the University of Toronto as well. I've been asked to talk for 20-25 minutes today on current and best practices in labor analgesia. So thank you for inviting me to present this topic. Before I present the topic, I just want to highlight that I have no disclosures or anything to declare. I will be mentioning some products in this talk. I have no interest in them myself whatsoever. So labor analgesia is a very, very, very broad topic to cover. This is a great information source from laborpains.com. It's run by the Obstetric Anaesthesia Association, who are a UK-based group of anaesthetists. This is excellent information, both for physicians as well as patients, which is why I've left a web link on this page. As you see, there could be a lot that I could talk about. I could be talking about all the non-pharmacological therapies for labor pains here on the left, or all the pharmacological therapies such as gas and air, morphine, remifentanil, epidurals on the right here. But I only have 20 minutes to talk to you. And the topic of discussion is what is the current and what is the best labor analgesia. So I am going to very specifically talk about and focus on one thing, and that is epidural analgesia, which continues to remain the gold standard for labor analgesia. And related to this, I'm going to be talking about the most up-to-date and evidence-based maintenance regime for labor analgesia through epidurals that we have. And this is the programmed intermittent epidural bolus, which I will be referring to as PIEB throughout this talk. So in order to understand where we are, we have to understand where we have come from, what has been done before, and where are we going. I'm going to also talk about the anatomy. This becomes important when you try to understand some of the findings that we do find in the publications related to programmed intermittent epidural bolus. And I'm also going to be talking about the pharmacology behind epidural loading and maintenance of the infusions in the epidural space. Finally, I'm going to go into the very specifics, the nitty-gritty of what it is we do, what doses, what concentrations, what times, etc., to make the PIEB regime a success that it is. And then I'm just going to have a nod to the future. Where are we going to go from here? So this is quite a busy slide, and I will summarize it on the next slide. This is the history of epidural analgesia for childbirth. And I just want to point out, here is 1949, and this is when we actually have the first continuous lumbar epidurals for labor. So really, epidural analgesia has only been around for about the past 70, 75 years for labor. And we've really come quite a long way. Back in 1909, they were doing intermittent caudal blocks, and a lot has changed in the past 75 to 100 years. So having started in 1909 with intermittent caudal blocks and having gone on to then having continuous epidural catheters, a lot changed in terms of the local anesthetics that we're using. We went from procaine to lidocaine, and now some places still use bupivacaine, some places are using ropivacaine. There's been a great development in terms of the technology that we're using. The catheters have become much better, the multi-orifice, they're kink resistant, they're very soft, they don't go into blood vessels. Bacterial filters was a big breakthrough as well. Prior to that, people used to have to fully scrub up in order to top up epidurals. And also there's been a development in technology in terms of smart pumps, which is what I'm going to talk about as part of this talk. There's been a big move to going to lower and lower and lower local anesthetic doses. And this is really important to prevent things like motor block, prolonged labors, and instrumental deliveries. And a big reason that we've had such success in that is because of the introduction of opioids in the epidural space. And then finally, really in the past 20 years, and this is what I'm going to be talking about, we've had a big change in progress in how we maintain our epidural infusions. And we've gone from patient-controlled analgesia to continuous infusions, and now the programmed intermittent epidural bolus. So in terms of the anatomy, the first stage of labor, the nerve fibers we need to block are the sympathetic fibers from T10 to L1. In the second stage of labor, we need to extend this to the sacral nerve roots and block down to S4. And when we talk about PIEB, it is important to remember these numbers. So what is going on in the epidural space? And how do we successfully achieve our epidural analgesia on a pharmacological level? This is all about achieving and maintaining what is a steady state. And there are two steps to this process. you have to first load your epidural. And if you don't load your epidural properly, step 2 is never going to work. Your maintenance regime is going to fail and your mother is going to be in pain. This is depicted on this slide here. So step 1 is what is going on with this straight line on the left. We have to give a sufficient volume and concentration of local anesthetic so that we are above the effective concentration to provide pain relief in the epidural space. And as I said, if you don't achieve step 1, if your mother is not comfortable after your load, then you're never going to achieve step 2, the maintenance, because you're always going to be below this effective concentration line. There are a number of ways we can achieve the maintenance step 2. We can do intermittent top-ups as we have here, or we could do a continuous infusion. So what do we do at Mount Sinai for step 1, our loading? So this was a study done by Professor Carvalho. It was presented at the SOAP conference in 2014. And we found that the effective volume for 90% of women, so this works in 90% of women, the loading dose of bupivacaine 0.125% with low-dose fentanyl, we found that following a test dose of either 3 mLs 2% lidocaine or 3 mLs of the bupivacaine 0.125% solution with low-dose fentanyl, we found that our effective volume, it was effective in 90% of women, was 12.4 mLs of the bupivacaine. So what this means is, when I put an epidural and I load my epidural, I give a 3 ml test dose of bupivacaine 0.125% with 3.3 mics per ml of fentanyl. And then over about 10 minutes, I top it up with a further 12 mLs of the same bupivacaine solution so that I give a total volume of 15 mLs. In terms of the effectiveness, this at a 20-minute interval in 90% of women should mean that they have a pain score of 0 or 1. And as I said, you have to achieve your load sufficiently, because if you don't, your maintenance regime is never going to work. So having done our load, we now come on to the maintenance. This takes us back to the late 1980s, early 1990s, where patient-controlled epidural analgesia was the maintenance regime of choice. And what this meant was, following your load, the woman would be comfortable, and then as the concentration dropped, she would start developing pain, and she would give herself through a button or through a nurse-assisted top-up, she would give herself a dose of anesthetic, and this would get her comfortable again. But then she would wait, the concentrations would drop, she would feel breakthrough pain again, and she'd have to push the button again. And this would go on and on and on over hours and hours of labor. The big issue and problem here is you're getting repeated episodes of maternal breakthrough pain, periods of discomfort which might be getting worse as labor progresses over what can be 12 hours, 18 hours, 24 hours. It can be a long period of time. So how do we address this problem of maternal breakthrough pain? This led in the early 1990s to the idea of a continuous background infusion. The idea was, if you have local anesthetic continually infusing, the mother would never feel this breakthrough pain. And initial studies, the results were mixed, but what they ultimately found was that if you did higher volumes or higher concentrations, you would get less maternal breakthrough pain. However, there was a trade-off with this. The trade-off was you would have higher local anesthetic consumption, you'd have denser motor block. This led to prolonged labors and higher instrumental deliveries. So they were able to address the problem of pain, but they traded it off with other adverse factors, which we don't want. We don't want dense motor block. We don't want prolonged labor. We don't want higher instrumental delivery rates. So we had a dilemma. And in 2005, people were starting to think, well, how can we address this idea? How can we know when to give the next top-up of solution to prevent them from getting pain? Because our continuous infusions are giving us motor block and prolonged labors. So this was the dilemma, and this led to the birth of the idea of programmed intermittent epidural bolus. This is a study done in 2006 by now Professor Wong, and this was one example of a study that was very rudimentary, very basic, but it did demonstrate the idea that you could do programmed intermittent epidural bolus. So what this group did is they had two patient groups. They had the continuous epidural infusion group, and this was the current standard of practice at the time. And so these women got a continuous infusion of 12 mLs per hour of low-dose bupivacaine with fentanyl, and the mothers also got a button as well, patient-controlled epidural analgesia, and if they needed extra, they could push the button. The second group was a group where they had an epidural catheter hooked up to two epidural pumps. And one of those pumps was, again, the button. The mother could push the button if she had breakthrough pain, the patient-controlled epidural analgesia. What was different about this second group was that Dr. Wong and her team, they hooked up a second epidural infusion pump to the exact same epidural, and they hooked up a pump that was programmed to give a bolus every 30 minutes of 6 mLs of the same low-dose bupivacaine fentanyl concentration. So it was a very rudimentary and basic design because it did rely on having two separate pumps hooked up into the same epidural catheter, the same epidural filter at the same time. But it was a success. They did show that in this group with the programmed bolus, they showed lower bupivacaine consumption and higher maternal satisfaction. There was an issue around safety, concern around safety. And the concern was it was possible, since you had two separate pumps working independently of each other, that the mother could push the button requesting more analgesia, and then the pump could fire at the same time. So there was a risk that the mom might get a double dose of local anesthetic at the same time, and this could lead to very high blocks. But as I said, it was a very basic design, it was a very rudimentary design, but it did prove the point that you could program a pump to give a dose of anesthetic before the mother felt breakthrough pain. In order to address the safety concerns from the study, manufacturers developed what we call smart pumps. These are the ones that we use here at Mount Sinai Hospital by Smith Medical. And these pumps have safety features incorporated into them. You can program them so that they can give whatever dose you want at whatever time interval you want, but they also have a safety feature so that the mum cannot push the button and give herself an extra excessive dose as the pump is about to fire or has just fired. So it has a safety element incorporated into it. So this then, having very basically proved the concept, it did lead to the question of what is the best regime? Should we give a very low volume and give it very regularly? Or should we give very high volumes but space them out further apart? And this was the next study by Professor Wong and her team. So here they're testing, should we give 2.5 mils, bolusing it every 15 minutes, or should we go for something larger, 10 mLs every hour? And what their study showed actually was that if you go for larger volumes and space them out over a longer period of time, you are going to get less local anesthetic consumption, and you have no worse outcomes. You have no worse pain. You have no more maternal requests for analgesia. You do not have higher motor block. You have the same modes of delivery, same durations of labor. So the significance of this is that it started to tell us, okay, if we're going to be bolusing these women, how do we do it? And the conclusion was we should probably be going for high volumes spaced out over long periods of time. So where are we now? The year is now 2019, and we now have systematic review and meta-analysis level evidence that shows that PIEB is the superior form of maternal epidural analgesia. There have been 11 randomized control studies, about 1,500 women, and it has conclusively, so clinically and statistically shown that PIEB leads to less breakthrough pain, less use of breakthrough requests, shorter duration of labor, less instrumental delivery, improved maternal satisfaction, and there is no increase in side effects. There's no increase in nausea and vomiting, no increase in hypotension, no increase in pruritus, same APGAR scores. So this is where we are now. Epidural analgesia is still the gold standard for labor analgesia, and PIEB is the current best maintenance regime. In terms of what's going on at an anatomical level, in 2016, this study was published showing how the local anesthetic spreads between the different maintenance regimes. So this is your epidural space, and the black line is the local anesthetic. And what they found was that with continuous infusions, the local anesthetic it tends to sink to the bottom of the epidural space. So you get concentrated local anesthetic not covering many dermatomes, and this explains why you had higher breakthrough pain and denser motor block. Conversely, in the bolus regime, you can see you've got much better spread and the anesthetic is not as concentrated. So this is why you had better maternal satisfaction, because you had better spread of your anesthetic and it wasn't concentrated in one area, which is why you have less motor block. So this leads us to the question, what is the best way to run this regime? How often should we bolus down the epidural with the pump? What's the ideal volume? What is the ideal concentration? How fast should we do the injection? So these are the studies that have come out of Mount Sinai Hospital by Professor Carvalho and Dr. Balki and our team here. And the very first study was done in 2017. And what we did is we had the 10 ml solution, as was previously published, of bupivacaine 0.0625% with low-dose fentanyl. And this study basically looked to try and determine what was the best time interval to provide the most maternal satisfaction with as few side effects as possible. And what actually we found here was that our best time was 40 minutes. So if we bolused 10 mLs of this low-dose bupivacaine fentanyl solution every 40 minutes, we had the best maternal satisfaction scores. If you went any lower than that, so a shorter time period, you started to develop high levels of motor block. Anything longer than that, you started to develop maternal breakthrough. But one problem that we picked up, regardless of how frequently you bolused the analgesic regime, problem that we found was that in 44% of women, they're getting a block well above T6. And as we discussed earlier, we only needed a block of T10. So we had this problem that we were getting very, very high block. We were getting high block, but the women weren't suffering side effects from it. They were not suffering from hypotension. They're not suffering from nausea and vomiting. They're not suffering from bradycardias. But it did lead us to try and perfect our regime. Could we perfect our regime? So the next study in 2018, we thought, okay, we've worked out what the ideal time is. It's 40 minutes. Maybe we're giving too much local anesthetic solution. So we tried to change how much we were bolusing. And we studied between bolusing 7 mLs, 8 mLs, 9 mLs, 11 mLs, 12 mLs. And we found that for the best maternal satisfaction, which was the primary outcome, 11 mLs was the ideal volume. However, once you started going above 10 mLs, you started to get higher amounts of motor block. So based on the fact that we were getting actually higher amounts of motor block, we decided, let's stick with 10 mLs. We still have 90% plus satisfied women and they don't have motor block. Our next question was, okay, what if we double the concentration and half the volume? Maybe that will stop us getting such high spread. And this was the next study that was done in 2019. And what we found was that for 0.125% bupivacaine with 2 mics per ml of fentanyl, the ideal bolus time was 35 minutes. So did we switch to this regime? We didn't. The reason why we didn't was because all of these studies terminated after 6 hours or if the woman was fully dilated. And if you have a labor that's 12 hours, 18 hours, 24 hours, you are just going to be using more and more and more local anesthetic and running the risk of motor block. It is a useful regime to know about because not all centers run 0.0625% bupivacaine. And we do sometimes switch women to this regime, particularly if they start complaining of interscapular pain, which is consistent with very high volumes in the epidural space. And then the final study we did here was we doubled the concentration, half the volume, a third time. So we had 0.25% bupivacaine with 8 mics per ml of fentanyl. And we found that the ideal time here was 20 minutes. However, this regime had absolutely no benefits compared to the other regimes. We still had high block, we were still getting motor block. There's no benefit to this. And at this duration every 20 minutes and low volumes, this is starting to trend towards being a continuous infusion again. So by coincidence, the very first study we did was actually the regime that we stuck with. So at Mount Sinai, we do a 10 ml bolus of bupivacaine, 0.0625% with 2 mics per ml of fentanyl. We initiate this 40 minutes after the load, and we spoke about what our loading regime earlier was. And this is effective in 90 to 95% of women. So the 5 to 10% of women that's not effective in, we also leave them with a patient-controlled epidural analgesia button. They can just give themselves a little bit more for those 5 to 10% of women who need a little bit extra. So what did we do? What do we think about this high block that we're getting? Going back to this diagram, this is what we think is going on. We think that we are getting T10 to L1 spread over where the majority of the local anesthetic is spreading when you bolus it. We think that what we're picking up when we get this block to T6, T5, T4 are these strands here of local anesthetic that are spreading up to the higher dermatomes. And the reason why we think this is because we're not seeing any side effects such as hypotension or bradycardia, these very high levels of block. So we think there's probably an insignificant, but yet a small amount of spread to these higher dermatomes. And maybe that's what we're picking up that explains the very high levels of block that we're seeing with PIEB. So how have these studies translated into our real life clinical practice at Mount Sinai? In 2011, we did a study looking at maternal satisfaction, and we found that in the first stage of labor, only 40% of women were pleased with their analgesia. After the introduction of PIEB, the percentage of women who were satisfied statistically increased. So in 2011, we had less than 50%. In 2017, after PIEB, we now have 62% of women. We saw a drop in the number of breakthrough top-ups that we needed, and overall increased maternal satisfaction. But interestingly, not 100%. And there are a number of reasons why not 100% of women are necessarily satisfied with this technique. Some of these women that we have come through are grand multips. Their labor goes very quickly, and sometimes we have women who are delivering as we're putting the epidural in. We have a very high BMI population here at Mount Sinai. We do epidurals and C-sections on women with BMIs of 60, 70, higher than 70. Studies haven't been done to demonstrate how the epidural analgesia is spreading in the epidural space of these women who are extremely obese. We still have some variation among staff in our practice. Some people put epidurals at L4-5, some do to L2-3. Not everyone always necessarily goes back to check that the load was successful. And having a successful load is important. If you have not loaded the epidural appropriately and the woman is not comfortable, then you're always behind. You don't have that effective concentration. So that might be another reason why we do not have a 100% success rate. So we still do have work to do. We still do have more studies to do in different patient population groups, different parity groups. We do still need to standardize our technique across different staff. We still need to have a standardized technique of addressing things like pain still being present after a load. Because remember, our loading regime is only effective in 90% of women. So to conclude, we've come a long way in the past 75 to 100 years. The current and best practice for labor analgesia does continue to be epidural analgesia, and the current best maintenance regime for that is the programmed intermittent epidural bolus. We still have more work to do. Not one regime fits all women. And I would be excited to see where we are in the next 75 to 100 years, because we've already come a long way. And so I'm very optimistic. I think the future is bright for epidural analgesia. Once again, thank you very much to everyone for attending today. Thank you to Dr. Deshmukh for inviting me. And I look forward to seeing you all at the question and answer session. Thank you very much.
Thank you, Dr. Ivan. That was indeed a wonderful presentation, a real journey. And the take-home message, I think, was the correct, that higher volume, higher interval, and lower concentration. In your case, and with a lot of research, I think it's 40 minutes, 10 ml, and 0.0625% of bupivacaine. So that was wonderful. Question and answers later on, some questions later on. We move on to the next session. Can you share the slide for the Yeah, the topic is ultrasound, a friend in need, morbidly obese parturient patient, locating the spine. I welcome Dr. Fabricio. Dr. Fabricio Zasso seems to be very polite because he has actually given only one line for his introduction. He's an assistant professor, Department of Anaesthesiology and Pain Medicine, Mount Sinai Hospital, University of Toronto, and he's Master of Health Science in Translation Research. So I hand over the mic to Fabricio, sir. Can we have the slide? Can we have the video on, please?
Good evening to all. My name is Fabrizio Battistella Zasso, and I'm an assistant professor at the University of Toronto. And I'm here today to discuss the use of ultrasonography in morbidly obese patients. I would like to thank the scientific committee of this obstetric anesthesia webinar for the invitation. So I have no disclosures to make. All the images and videos used in this presentation, I had authorization from either the authors or the patient involved. These are the learning objectives from this presentation: review the use of ultrasonography for neuroaxial blocks, discuss the use of ultrasonography for neuroaxial blocks in obese pregnant patients, and discuss benefits and limitations of this technique in this population. So we all learned that to perform neuroaxial blocks based on findings from our palpation. However, back in 2000, a group from UK published on anesthesia that when they checked the palpation technique with an MRI, only 30% of the time the lumbar space that was identified was correct by palpation. Outstandingly, 51% of the times, actually, the correct space was one space above. And more even like alarming was that this difference could be up to 4 space. So it could be much higher in the spine that we thought. So in 2001, Groh et al., a group from Germany, described the use of ultrasound technique for neuroaxial anesthesia. So this technique involves a few particularities. There are some challenges because the spinal gives us a very narrow window due to the complexity of the encasement of bones. And also for this technique, we need to find deeper structures when we compare to other uses of ultrasound, such as vascular access and either like superficial peripheral nerve blocks. So regarding technique, we have two useful windows. One is the paramedian longitudinal approach, and one is the median transverse approach. We need to use a low frequency curved probe as we need to see deeper structures. These allow us to see from 4 to 16 centimeters deep. However, this gives a lower resolution in our image. So first, we're going to start with the paramedian longitudinal approach. The scan starts in the sacral area, 3 centimeters lateral from midline. And our goal is to see, as you can see in the picture, the first image needs to be the sacrum, that is a straight line in this area. As you move your probe up, you're going to see a saw pattern. And this saw pattern means that, as you can see on the right image, the higher part of your saw, that's the teeth of the saw, it's the articular process. And when you, in between these teeth, you can see the interspace. So below the articular process, actually you have bone, so it's a hypoechoic image, so you cannot see anything. But in between the teeth, you can see the interspace. And this, what we want to see is these like 2 small horizontal lines. The upper one, or the closer to the skin or the probe, is the conjunction of ligament flavum and dura mater. And the lower one is the conjunction of the posterior vertebral body, the longitudinal ligament, and the anterior dura mater. So in between both, you have the spinal canal. Our goal is the above line, the ligament flavum together with the dura mater. When we move, so we do the paramedian approach, and then we're going to see the interspaces. We can mark the interspaces. Then we move to the transverse approach, and here we're looking for the flying bat. So first of all, you want to find your spinous process. So maybe you need to move your probe a little bit up and down and see this acoustic shadow, that's the spinous process, because again, below that structure, you're not going to see anything, just black shadow is hypoechoic, the bone. As you again move your probe a little bit up or down, you're going to see the interspace, and that's the image that you're looking for. Mainly, you can want again to see both horizontal, small horizontal lines. The closer one to the skin or probe, ligament flavum and dura mater. The lower one will be conjunction of vertebral body, the posterior ligament, or the anterior dura mater. And this is called the equal sign. So this is our goal, and we want to see the best image on the equal sign. So, and why we call flying bat, as you can see on this image, actually it resembles a flying bat. So this is how you mark. First you mark actually on the paramedian, and then when you move to the transverse, you're going to mark the midline, and again, you're going to check if your previous marks are correct. If not, you're going to do new marks. Once you have both marks, you're going to draw a line, and the conjunction of the lines will be your insertion point. So now I'm going to show you 2 videos, one with the paramedian approach and one with the transverse approach.
Paramedian longitudinal plane scanning is performed to identify the interspace levels, to verify the findings of transverse scanning, or to determine the insertion point for a paramedian puncture. The probe is held parallel to the axis of the spine, 2 to 3 centimeters off the midline. Images of the alternating lamina and interspaces are seen. The lamina are hyperechoic, while the interspaces appear as 2 parallel bands between them. The top band represents the ligamentum flavum and posterior dura, while the bottom one consists of the vertebral body and the anterior dura. Once an optimum image is centralized and frozen, the depth to the epidural space is measured. To determine the insertion point for a paramedian puncture, the skin is marked at the center of both the longitudinal axis and the lateral sides of the probe. The extensions of these two marks are then joined. Transverse plane scanning is performed to determine the midline puncture point and the depth to the epidural space. As the probe is held perpendicular to the axis of the spine and against the spinous process, a bright signal is seen in the center with a dark vertical shadow below, identifying the midline. Slight movement of the probe up and down allows visualization of the interspace between two spinous processes. Within this interspace, the ligamentum flavum and the posterior dura appear as one single central band on the top. The band below represents the vertebral body and the anterior dura. The articular and the transverse processes appear as bilateral symmetrical white structures. With the interspace centered on the screen, the depth to the epidural space is measured. The midline of the spine is then marked, followed by the interspace on both sides of the probe. The insertion point is then determined by extending these lines.
So I'd like to thank Dr. Balki for allowing us to use this video that she prepared. But the advantages that the literature show about using ultrasonography for epidural placement was firstly stated by Grau et al. In the early 2000s, after he published the technique, and it showed in several studies that it improves success of epidural catheter placement, improves success of block, minimize the risk of complications such as dural puncture, and improves patient satisfaction. However, there are limitations, and the one that I advocated are: one, it increases time. So Ansari et al. Showed that an experienced person doing ultrasonography in pregnant patients will take 75 seconds to acquire the images. So this is something that over time, as you train the technique, you're going to reduce more and more and more. You have also the cost of the equipment. Of course, this is mainly at the beginning. After, with time, this is going to be diluted. Technical difficulties. This is another limitation. And actually, as you become more experienced, your difficulties will be less and less. Another limitation is that this is a pre-procedure scan, so not real time. You don't have this technique yet, or this ability yet. So if the patient, we need to have the patient in the same position that when doing the scan and after doing the block. So if the patient is in pain, in labor, sometimes it's challenging to have this. So and now about obese pregnant patients. So we know that this particular population have an increased chance of complications, mainly dural puncture, do not transmit as post-dural puncture headache, because obese patients have an increased abdominal pressure that reduces the chance of that. But of course, they have like an increased chance of dural puncture and accidental intravascular placement of the catheter epidural. Of course, there is also an increased chance of failure of the axial anesthesia. And this correlates directly with the inability to identify anatomical structures by palpation and inability to determine the distance between skin and epidural space. So this is study from Sahin et al. 2014. They recruited 100 patients, 50 with a BMI below 30 and 50 with BMI above 30, and divided each of these in two new groups, like so. 4 groups of 25, one ultrasound in high BMI, one ultrasound in low BMI, and then one of each in low BMI. And the conclusion was that the pre-insertion ultrasound examination improves the success rate of subarachnoid access on the first attempt and reduces the number of puncture attempts in obese pregnant patients. But what are the challenges that we face when we're using this special population? Mainly because you already are using probe that will give you low resolution. And then these patients normally have the structures that you want to look into deeper. So image resolution will be even lower. And another thing is like when you're trying to do the imaging, you might compress the subcutaneous tissue that's very somewhat large in these patients, 4 or 5 centimeters. So then you should be careful with that you might underestimate your depth of your structures. Something that you can do is when you find your image before measuring the distance, you can just retract and slightly press the probe against the skin, and then you're going to have actually the correct distance. So this is an image that you can see in an obese patient. You can see on the top left image that actually you have a large subcutaneous tissue layer, and then even your spinous process is deeper. So the image is not so clear. It's 4.25 centimeters on this patient. And when you go to the other image, the equal sign, you can barely see. It's very subtle. And it's like 7.22 centimeters deep. So more challenging to see the structures. And in this patient that we actually performed recently, the neuraxial, and was a patient with a BMI of 68, you can see the first image is actually the paramedian approach, and you barely can see the interspace. That's where you have the midline, and the very light straight line that you have there is actually the conjunction of the ligament flava and dura mater. When you go to the transverse approach on the right bottom image, you can see that also your image is not so easy to identify. And here again, you have this slightly brighter line that's actually ligament flava and dura mater again. And you can see that the depth is around also 7 centimeters, large subcutaneous tissue again. So these kind of patients is actually challenging. These are 2 studies done at Mount Sinai. The left one, they just, the investigators just want to make sure that the distance in the measuring the ultrasound correlate to actually with the distance that the needle navigate, and it was proved that yes, it correlates very well. And on the right, they measure the distance the needle enter the skin and the structures with both transverse and paramedian structures, and they also correlate really well with both approaches. However, what I want to show you is that in the left study, the imaging was rated as good, fair, and poor. There were 46 patients recruited. 24 of them were class 3 obesity, so BMI above 40. And the visualization of the ligament flava and dura mater unit was poor in 9% of the patients. And the visualization of the spinal process poor in 2% of the patients. The second study, also the imaging was rated as good, poor, and inconclusive, so no discernible structures. And out of 6 patients, 20 patients were class 3 obesity. The transverse approach, we had 19 poor/inconclusive images, and in the paramedian approach, 8 of these. So just to highlight that actually the imaging on these patients is challenging. Okay, so if the images are challenging, why still are going to aim for doing the ultrasound on these patients? So what are the benefits, even if you have a poor or inconclusive ultrasound imaging? So the main benefits are that you most likely will be able to identify the midline at least. And this is already something that can help to direct your neuraxial block. And when you can see the spinous process, you just assume that in between two spinous processes, the gap will be in an interspace. So these are already helpful in these patients, much more than probably these patients you are not going to be able to have any kind of idea just by palpation. So this is a systematic review that was published this year in Anesthesia, comparing palpation and per-procedure ultrasound in obstetrics patients. And then you can see that in general, for first pass success rate, the ultrasound is better than landmarks. Sorry, let's just move this here. In terms of, for easy patients, there is not such a big difference, but when you go to the difficult patients that include the obese, it's even more marked that is beneficial to use ultrasound. This is another study that showed, sorry, this is the same study showing the time for using. And you can see that when you have easy patients, it's even better to use landmark, the palpation technique. However, when you go to the difficult, there is no difference in time. So you benefit, the time that you spend doing the images, actually you gain after doing the procedure because you have some indication of how to do it. So in conclusion, the use of per-procedure ultrasound increased the first pass success rate and decreased the incidence of complications without an increase in overall procedure time when compared with the traditional method of landmark palpation. So Mount Sinai Hospital experience about managing obese patients. We are a high-risk obstetric reference hospital, and we have a lot of high BMI patients. I consider a number every week. A lot of patients on BMI 40 and 50, between 40 and 50, some above 50, 60, sometimes even 70. And I had one patient that was even 80. So obesity is a global pandemic, mostly, even more in North America. So for these patients, when we have a cesarean section, we give a preference for epidurals. We avoid single shot spinals because the procedure is normally longer. And then we might be stuck in a situation that the block wears off, and then we have to manage the airway that we want to avoid as much as possible. CSC is also like a controversial technique that because you don't test your epidural before starting the C-section. So we prefer epidural approach. We do higher labor epidural placement, L1, L2, T12, L1, because also some surgeons use higher incisions, and in this case, we are prepared for a C-section later on, and it's easier to do epidural in these levels because normally you have more subcutaneous tissue and not so much fat tissue. We insert the catheter at least 7 centimeters deep. We do sui test, or we do transduction of waveform of the catheter to check if they are well placed, and we reinforce the forced fixation to avoid dislodgement. We have low threshold for replacement of these epidurals because this is we normally do like for patients that come in for labor, we do early epidurals, and sometimes they stay like 24 hours, 36 hours in labor, and sometimes they sweat, and then it's easy to dislodge it, and then we need to replace. So reinforced fixation. And also, we need to be aware that these patients, they are a combo. They all, not infrequently, they have difficult vascular access and difficult airway together. So take-home message, ultrasound facilitates neoaxial blocks in obese pregnant patients. Only practicing regular patients make you prepare for using ultrasound in obese patients, and is a really useful technique for epidural failure. Every time that I need to replace an epidural, I use the ultrasound. So these are my references that I use in this presentation. Thank you very much for the opportunity.
Okay. Thank you, Dr. Fabricio. That was a really good, excellent presentation. And we are now ready we can have some questions now. I can see Dr. Fabricio and Dr. Evan Wild, both are there live. Good morning, I should say, to both of you. Welcome, sir. Okay, so now let's see in the chat box. Do we have any questions? Okay. So, okay. So this is a question from Dr. Pratibha Deshmukh, madam. I think it must be to Dr. Wild. Has PEB completely replaced PCEA? I think we cannot hear him.
Hi, can you hear me now?
Go ahead, yeah.
Excellent, excellent. Yeah, thank you very much for the question. So the main limit, so PIEB is certainly the best practice for epidurals. The main limitation with PIB at the moment is that you need to have the pumps from the manufacturer with the programming. So I'll give an example where I finished my residency in McMaster, for example, which is about 20 kilometers down the road. They're still running continuous infusions because they're currently in the process of buying all the pumps from the manufacturer with the PIEB software. So that's the biggest limitation to PIEB is having the pumps for it. Even when we do PIEB, we still combine it with PCEA because all the studies for PIEB and the dosing, they're all about, they call it ED90 or ED95 dosing studies. So the regimes are only effective in 90 to 95% of women. So there will still be some women who need a bit of extra local anesthetic, either in concentration or volume or dose. And so we always combine whatever regime we're doing. We still always have the PCEA button available for them. We just go for much lower volumes yeah, much lower volumes and not a huge lockout, so they can't give themselves a big dose. So I think to answer your question, PIEB is the current best practice. It should be what we're trying to strive for and achieve, but the biggest limitation is the technology and having it in order to run the PIEB dosing. Oh, sorry, I can't hear you.
Dipali madam, you have to unmute yourself.
Yeah. Am I audible?
Yes, yes.
Okay. So this is a question for Dr. Fabricio. Will it reduce the acoustic window in obesity and increase lordosis of pregnancy? This is a question.
Thank you for the question. I'm not really aware of any improving that. And please, like Dr. Balk and Dr. Wild, jump in if you have any information on that. But I think that's reasonable to expect that might happen, but we don't have. But when we touch in this subject, I think it's really important to reinforce that in this particular population as well is really important the positioning when we're doing the epidural placement. Sometimes we worry with much other things because they are complex patients, but positioning is really important because it always will help to open the space and improve the acoustic window. So we actually in our institution, we have some positioning devices that help to best have the best position as possible to perform both the ultrasound and after the epidural placement.
Okay. Can I add something here?
Yes, sure. Yes.
I don't think acoustic window will be affected with in obese patients because this window is between the bones. So fatty or whatever subcutaneous tissue or any tissue is not going to affect the window. It's the window created between the bones. So and bony the vertebral column is not different, right? In obese, it's the subcutaneous tissue or like obesity that's causing the effect. So I don't think window will be different. That's the bottom line. That's the answer. It shouldn't be affected. You should see the same amount. Only thing is that because it's so deep, it's hard for us to visualize those areas that we need to.
Thank you.
Yeah, thank you, madam. Thank you. Yeah, that's really a wonderful point you brought up. Actually, we are running behind the schedule. If are there any questions from the audience?
Okay, there's one question I would like to ask Dr. Ivan. You said that you have to combine both PIEB as well as patient-controlled PCEA. So wouldn't the volume exceed? Wouldn't that give rise to a high block if the patient keeps pressing the button and demanding? Because everyone has a different pain tolerance also.
So yeah, it's a good question. So what I'd say is really important in terms of instructing the patient how and when to push the button. Can it lead to high block? Well, we already see the high block with the PIEB. So the question what I'd ask is, if the patient is in pain, I'd firstly identify why is that. So you need to exclude any other problems: kink catheter, unilateral block, paravertebral insertion accidentally. I think it's really important to exclude those. The other thing we do is we set a maximum limit of, I think, 30 mLs in our institution, so that the women cannot just sit there pushing the button. And in fact, we then instruct our women that, if they're pushing it more than once or twice, they should be calling for the anesthesiologist to come and assess their epidural. It might be that they just, you're right, women do have different pain tolerances. It might be that they need something like a different concentration, so the slightly higher concentration of the 0.125 bupivacaine. And then the other feature is that I think the pumps are programmed so you cannot immediately give yourself a dose just proceeding to or just after receiving the dose. When we talk about high block, this is something that needs more research. How do we standardize this definition of high block? Currently, we're testing it to ice, but so that's when you go from feeling a little bit cold to ice cold. There's a question around whether or not we should be testing it from the sensation of you feel nothing to when you start feeling a little bit of cold, because the concentration is so dilute that probably this incidence of high block that we're experiencing, we need to standardize the definition. Maybe we need that sensation of where you go from feeling nothing to feeling a little bit of cold, because that is a much lower dermatome, and that is probably what is covering the T10 dermatome. Probably what we're feeling with this sort of going from a little bit of cold to ice cold might not be the correct way of testing the block, but there's no standardized international definition of how to test the block. Potentially, yes, you can. So to answer your question, potentially, yes, you could get high blocks. We already see high blocks, but as I explained with that diagram, and as we don't have a standardized definition, probably what we are seeing is the majority of local anesthetic is covering T10 to L1. And probably what we're seeing is a little bit of local anesthetic spreading a little bit higher. We need to standardize the definition to answer that question. I'm not sure if that answers your question, or if I've said it in a very wordy way.
No, thank you so much. That really gave the point, actually. Any other questions? Okay, so that was wonderful. Actually, both the speakers were wonderful, and they have answered our queries. And we have learned a lot about labor analgesia, and really, indeed, ultrasound has been a friend in obese parturient patient, and in most of the regional anesthesia purposes, actually ultrasound is real good friend. We have been using it since last 2-3 years, and it's really proving a real-time friend. So I think now I give the mic to Deepak to complete the formalities and facilitate the speakers, so that we can move on to session 3.
Thank you, ma'am. It was an excellent session. I thank the speakers, Dr. Ivan sir and Dr. Fabricio sir. Please accept the e-mementos as a token of our appreciation. I thank the chairpersons, Dr. Archana Deshpande ma'am and Dr. Deepali Manlik ma'am. Ma'am, please accept our token of appreciation, the e-mementos.
Thank you.
Thank you.
Stop. A very good evening, dear all. Greetings from Datta Meghe Medical College and Indian Society of Anaesthesiologists, Nagpur City branch. Senior anesthesiologist Dr. Narendra Tamne sir is our MMC observer today. We welcome you, sir. I, Dr. Anjali Modak, professor, along with Dr. Kirti.
And I, Dr. Parag Sabay, Assistant Professor, Department of Anaesthesiology, Datta Meghe Medical College, Nagpur, would like to start and move on to our third session of this today's webinar.
Enhanced recovery after surgery was introduced to reduce the length of hospital stay and improve patient satisfaction in surgical patients. Although ERAS protocols have been successfully implemented across various surgical patients, there are many challenges in implementing ERAS in obstetrics. What is our role as anesthesiologists in the preoperative, in the intraoperative, and the post-operative period to enhance recovery after cesarean section? And what challenges do we face?
To speak on this very important and relevant topic, that is enhanced recovery after cesarean, easier said than done. I welcome Dr. Sunanda Gupta ma'am for this topic. About ma'am, she has vast experience in obstetric anesthesia. Madam is professor and head of department at Gitanjali Medical College and Hospital, Udaipur. She has 140 papers in national. Yeah, about Dr. Sunanda Gupta ma'am, she's a professor and head of department at Gitanjali Medical College and Hospital, Udaipur. She has 140 papers in national and international journals. She's also editor of the textbook on obstetric anesthesia. She has covered a chapter 14 in national book and 6 in international book. Ma'am is founder, president of Association of Obstetric Anaesthesiologists. Ma'am is also executive member of Obstetric Anaesthesia Society of Asia Oceania. She's executive member of and working committee at Indian College of Anaesthesiologists. She's member of Obstetric Anesthesia Association at UK, and she's president and action research training in health at Udaipur. She has 6 awards on her name and 8 orations. Her field of interest is obstetric anesthesiology. Yeah, I request all the participants to keep yourself muted. Any queries will be taken after this session. Over to Dr. Sunanda Gupta.
A very good day to all the international faculty, friends, and delegates. Thank you very much, Pratibha, for inviting me, and I'm so happy to note your attempts at spreading awareness regarding obstetric anesthesia in the country. Now, ERAS protocols have gained widespread popularity, perhaps because the interdisciplinary approach required to create care pathways, bring an opportunity to replace traditions that are poorly supported by evidence. Now, it has also placed patients before institutional needs, and it holds us health professionals more accountable to what we do. So before I start, I bring to you greetings from my medical college, that is Gitanjali Medical College and Hospital in Udaipur. It is a 1100 bedded hospital, and it has got about 100 beds of ICU. And we have got all the super specialties, and of course, obstetric anesthesia is widely practiced here. I have no financial disclosure or conflicts of interest with the presented material in this presentation. And in the next 20 minutes or so, what are we going to look into? What exactly is ERAS? Why has it been implemented? Why did we feel the need for that? What are the components of ERAS protocol? What are the evidence for efficacy of ERAS? And what are the challenges for implementing ERAS in the end we'll discuss. So it is a comprehensive interdisciplinary protocol-based approach to a surgical journey, which begins at the preoperative visit and extends into the postoperative period. Now, the goal of ERAS is to help the parturian return quickly back to her normal pre-operative physiological functions. And the goal of ERAS is to, this is achieved through improving the quality of care, decreasing the cost, and increasing patient satisfaction. So why has ERAS been implemented? If you look at this article, which has recently been published in the British Medical Journal Global Health in 2021, it was in August. So they looked at trends and projections of the cesarean section rates, both globally, and the regional estimates have been presented. And about 154 countries, cesarean section rates were recorded. And this represents the 94.5% of the world's live births in 2018. The highest incidence of cesarean section rates, around 58.1%, has been seen in the Dominican Republic, which is followed by Brazil, Cyprus, Egypt, and Turkey. While the lowest cesarean section rates comes from Chad, Niger, Ethiopia, Madagascar, and Cameroon. And this article, what it highlights is that at present, the incidence of cesarean section rate is somewhere around 21.1%. But by 2030, this is going to increase to 28.5%. So cesarean section issue is a global priority. The SOAP consensus statement states that the goal of Iraq is to help provide all women with evidence-based, patient-centered care using a standardized multidisciplinary approach that optimizes recovery from cesarean delivery and improves the maternal and newborn outcomes. So what are the components of ERAS protocol? Now, if you look at the components, as we said earlier, it ranges from preoperative to the postoperative period. There are about 5 protocols here. And in the intraoperative period, there are about 9 elements. And in the postoperative period, there are about 11 elements. And these are summarized into the following protocols: pre-admission counseling and education, oral fluids up to 2 hours pre-surgery, carbohydrate preloading, avoiding and not overlooking any fluid overload, multimodal non-opiate analgesics, peripheral nerve blocks along with multimodal analgesia, prevention of both intra and postoperative vomiting. If you are using general anesthesia, using short-acting anesthetic agents so that postoperative recovery is faster. If it is laparoscopy, no drains here, no nasogastric tubes, and also urinary catheters are removed early on. Early mobilization, early return to function, and then what is most important is audit of compliance. Did she really, were your instructions really followed? So the ERAS Society has further reduced the number of elements which have been put forward by SOAP. Here in the preoperative period, out of the 8 elements, 5 elements are used. Intraoperative, out of the 9, 4 are used. In the postoperative period, out of the 11, 9 are used. And there is another 4th one, neonatal. 6 elements where here ERAS Society uses only 1 of them. So the reduction in the number of elements in the ERAS protocols is basically so that we can implement it easily in our parturient population who are undergoing cesarean section. So to limit fasting in these patients, SOAP advocates that we need to keep the patient well hydrated, both orally as well as intravenously, and limiting the fasting or no fasting reduces the aspiration risk and also limits hypovolemia. So the preoperative targets are that apple juice can be given, which is a clear fluid up to 500 ml. Solids up to 6 hours should be given. If it is non-fatty meal should be given up to 6 hours. And a fatty meal can be given 8 hours before the surgery. Clear liquids to 2 hours prior. This is a definition of a light meal. Non-fizzy sports drinks can be given, which are clearless. Maltodextrin has been used as one of the carbohydrate drinks, but Glucon-D is what we used, and we used it a day before surgery, 4 teaspoons in 800 ml, and on the day of surgery, we used 2 teaspoons in 250 ml. What is the advantage of these preoperative carbohydrates? It increases the insulin sensitivity, increases anabolic metabolism, and prevents hyperglycemia, and by protein retention, it prevents any decrease in the lean body mass. The increase in glucose control, or decrease in postoperative nausea, vomiting, an enhanced gastric emptying, and an increase in patient comfort all improves the quality of recovery in these patients. Now, multimodal analgesia, which involves all the steps of the ascending pathway and the descending pathway, includes blocking the peripheral nociception with local anesthetics, field block, NSAIDs or COXIPs. The peripheral nerve is blocked with local anesthetics, and the dorsal horn, here it is blocked by local anesthetics, opioids or alpha-2 agonists, and thus it becomes a multimodal technique of analgesia, so that the opioids, alpha-2 agonists, acetaminophen, the inhibitors, and ketamine, carbapenem, pregabalin, all are used to prevent any nociceptive stimuli reaching the brain. So, ERAS and cesarean, what does the evidence say? We look at the current literature, about 3 or 4 papers. This was the earliest paper that came in 2015, and it was a tertiary care experience from UK. And what they concluded was that ERAS is, especially women who were presenting for obstetric surgery with the indication 1 previous cesarean section, were more likely to leave the hospital earlier as compared to other indications. The percentage of patients discharged on the day following surgery, following elective cesarean section, was much higher when this protocol was implemented. The second article comes from 2020 from Carvalho, Stanford University, and they looked at a systematic review of interventions and outcomes. And they looked at about 42 study interventions and 90 outcome measures. And they found that there was a reduction in the hospital stay, and the cost was also reduced. However, there was low-level evidence supporting all outcomes which are evaluated, and they thought that more study in larger population should be done to find out the exact benefits. However, none reported any harm. This other study comes from the Frontiers in Medicine, and this was published in August 2021. And this is also a systematic review and meta-analysis of RCTs and observational studies. Comes from China, and it involves more than 16,000 patients. And what they concluded was that it is a feasible, effective, and safe technique, and however limited to the quantity and quality of the studies. Further large and randomized RCT should be undertaken to find out the exact advantage. Enhanced recovery. So now let us look at what are the challenges that we face while implementing this. So this article from AJOG advocates that obstetricians must implement enhanced recovery protocols, and this was editorial. So they say that the barriers to ERAS implementation basically occur because we are shifting elements of care from inpatient to the outpatient setting, and ERAS has been basically designed for planned surgery, and most of the time what we have is unscheduled cesarean sections. So maybe we need to change the protocols or modify those protocols. And it really requires champions who are passionate, who are dedicated, knowledgeable, and really want to implement this protocol and provide overall safety and comfort to our participants. So the key findings were that to implement this protocol in toto was quite difficult, but if you used a focused pathway in the emergency patients, which need to be implemented just 30 or 60 minutes before the skin incision, and in unscheduled, in scheduled deliveries, you could use the longer optimized pathway that manages antenatal education, maternal comorbidities, and immediate neonatal needs at delivery. Now, this article, which comes from Anjan Trikha and this group, was published in 2020 in the Journal of Obstetric Anaesthesia and Critical Care. And it is an editorial where he talks about whether we are really ready to implement this in our country. Because remember, most of the studies we are looking at has come from the Western world. So he outlines, he and his group outlines some of the problems that we face. First of all, the early discharge. Now, the problem with early discharge in our situation is that most of our population is illiterate. We have lack of trained ERAS staff. And when they go back home, these patients are unable to recognize the criticality of the situation. And since they do not recognize this, they do not come back to the hospitals for readmission. So that could be a problem. And apart from this, there's a greater rural-urban divide. And for bridging the rural-urban divide, it's to reduce the maternal mortality. The Indian government had tried started the Janani Suraksha Yojana. And the glaring disparity between the rural-urban divide spurts from the fact that in developing countries, rural women mortality rate is pretty high, wherein the provision of modern amenities and healthcare facilities is definitely lacking. So these rural women often do not have access to large public hospitals which are implementing the ERAS protocols. So to narrow this social gap, the government used this new theory or yojana, we call it. And the only problem with it is that when the patient has to be readmitted, in that situation, the government does not pay any finances, and so it becomes a financial burden on these patients. These programs, these programs do not provide any incentives to these rural women. The second is we do not have a strong telecommunication. There is poor infrastructure in these villages, so transport from the villages is also difficult. So as I said, readmission becomes a financial burden on these patients. Now, if the neonate has some special health problems, then the mother is not discharged from the hospital. Now, to implement the ERAS pathway, the concept of perioperative surgical homes has developed to its extent beyond the immediate perioperative period as an external outpatient setting. And wherein an anesthesiologist and an intensivist together with a nurse practitioners provides and integrates perioperative care, including post-discharge plans. So this concept is coming up in the developed world, but has yet to catch up in our country, and this will provide an important role for anesthesiologists in this area and can be lead physicians in the perioperative care of the obstetric ERAS parturients. Now, post-operative factors again is a problem because it cannot be implemented in comorbid situations, wherein 6 to 12 weeks follow-up after birth in complicated pregnancy is advocated, especially in gestational diabetes, mellitus, and placental complications. You cannot really discharge these patients. So ERAS implementation in the high-risk parturients in India is still big problem. Most of these patients have low hemoglobin levels. India has the highest ratio of women who are anemic. So implementing this protocol in the anemic women again would be disastrous. There is lack of equipped OT, so we do not have warmers. The fluids are also run cold, so hypothermia would be a major issue in the winter climates. For elective surgery, these protocols have been planned for elective surgery. So for unscheduled cesarean sections, we need to be more flexible and implement elements which are reduced. Rather than taking all the 9 elements, we could cut it down to about 4 elements. Now, there is a traditional after childbirth so-called postpartum confinement, which is present in every Indian house, or sitting the month, wherein the woman is not allowed to go out of her room. She is kept in, and the baby and the mother is kept. In some cases, she is provided with prolonged rest, special diet, and personal hygiene is at a low. So an anemic patient might suffer in these situations. Now, this is an article which was published recently in June. It was a poster presentation of the impact of implementation of enhanced recovery after surgical protocol in elective cesarean sections from my department. And we looked at about 160 patients with traditional protocol, 80 patients, and ERAS protocol in 80 patients, and this study was completed in December 2020. The primary outcome measure included the postoperative duration of stay, while the quality of recovery, the postoperative pain, the initiation of breastfeeding, and postoperative ambulation were secondary outcome measures. And if you can look at all the comparison of ERAS and the traditional group, you'll find that all the P values were highly significant. So we found the obstetrician, only one obstetrician was generally accepting to put in the ERAS protocol for his patients. But later on, when the results came out, most of the unit heads and obstetricians were ready to implement this in their ward. So now we have this ERAS protocol regularly in place. Now what we did, as we talked about before, this ERAS protocol was not implemented in total, but we had cut down on the number of elements at each stage. So the potential benefits of ERAS for cesarean delivery, according to the literature, shows that there is reduction in the opioid consumption, there is improved patient satisfaction, there is a reduction in cost, faster return to bowel motions, and early discharge to home of these patients. So in the end, the key points, enhanced recovery after cesarean provides evidence-based standardized care for the perioperative period. And if you are incorporating ERA for cesarean sections, you need to follow both the focused and the optimal pathway so that it will be rapidly taken up. This uptake of protocol becomes more rapid and facilitate its dissemination through making the protocol more accessible. Now, several barriers to ERAS implementation will need to be addressed to facilitate widespread protocol adoption. And I hope in the near future, with the rising sun, we'll be able to implement the ERAS protocol for our parturients on a widespread manner. Thank you.
Stop sharing.
Thank you, ma'am, for such an elaborative session. This would definitely help obstetric anesthesiologists in their practice, and hope we will be able to implement ERAS protocols in our practice also. Thank you.
Moving on to our next deliberation. Obstetric patients are considered at increased risk of post-dural puncture headache because of their young age, their gender, and widespread use of neuroaxial blocks in them. Although PDPH may reduce spontaneously or resolve spontaneously, it has the potential to cause significant morbidity and interfere with the mother's ability to take care of herself or her baby. It may extend the length of hospital stay, and it may also become a chronic headache in some cases. Therefore, we as anesthesiologists need to be familiar with the prevention of PDPH, and if at all it occurs, its treatment. To talk on this,
today we have very eminent speaker with us, Dr. Vasudha Misra ma'am, who has excellent academic career contributing from 3 countries. Ma'am has completed her basic medical education, that is MBBS from India. Further, ma'am has Dr. Vasudha Misra ma'am, who has excellent academic career contributing from 3 countries. Ma'am has completed her basic medical education, that is MBBS from India. Further, ma'am has pursued postgraduate training in anesthesia at Warwickshire School of Anesthesia, West Midland, Dundee from UK. After FRCA, ma'am has moved her academic career in the direction of her special interest of obstetric anesthesia and pursued fellowship in obstetric anesthesia from University of Montego. She has also served as fellowship director at the same university. Ma'am has done FRCPC and worked as staff anesthesiologist. She has worked as site lead for obstetric anesthesia at Boniface Hospital, Winnipeg. Ma'am has recently relocated at Ontario and working as staff anesthesiologist position at Niagara Health. She is a very good teacher and actively involved in teaching residents and medical students. Over to you, ma'am. I request all the participants to kindly mute their audio and put their queries in the chat box. We will have a question and answer session at the end. Thank you.
Hello, good evening, everyone. Today, I'm going to talk about post-dural puncture headache. Post-dural puncture headache is a major complication of neuroaxial anesthesia in obstetrics, as we are all aware. This can occur both following spinal anesthesia as well as inadvertent dural punctures during epidural techniques. So the objectives of our talk today is we'll dive a little bit into the background and the history of post-dural puncture headache. We'll review the pathophysiology and look at the presentation for post-dural puncture headache. We'll understand the risk factors and how they help us to reduce the incidence and severity of post-dural puncture headache. And we'll also try to understand the current evidence in prevention and treatment of post-dural puncture headache. So post-dural puncture headache, it was first reported in the late 19th century by a German surgeon, Dr. August Beer. Beer had used himself as a subject to demonstrate spinal block. He was the first person to use a spinal cocaine to produce surgical anesthesia, following which he realized he experienced a disabling headache after the procedure. In his opinion, the headache occurred because of excessive loss of cerebrospinal fluid, which disappeared on lying flat, and he had the headache come back when he was sitting upright, which he presumed was post-dural puncture headache, and this was first published by him in 1898. So pathophysiology of post-dural puncture headache, obviously, as we are all aware, the CSF leaking from the dural puncture site leads to a loss of CSF fluid pressure around the spinal cord, And this causes a loss of buoyancy supporting the brain, which then the patient assuming the upright position, the brain starts to sag and cause tension on the meninges and the other pain sensitive intracranial structures, creating the pain sensation. We are also aware that the normal CSF pressure is in the range of 5 to 15 centimeters of water, but when we sit upright, can increase up to 40 centimeters of water, causing that gradient to increase that traction, causing stretching and further pain due to those pain structures. Having said that, it is not entirely because of CSF leak that the pain occurs during post-dural puncture headache. Much of the pain is not related to the CSF leak and is instead caused by vascular distension. As the body assumes that vertical position, this hydrostatic gradient across the brain increases, and there's more CSF exiting through the dural puncture. The body then attempts to compensate this by the loss of intracranial volume by vasodilation. And this process is reversed when the patient tries to return to the supine position, and hence the headache is relieved. So these are the images that show the difference in caliber of the blood vessel in a patient who presented with low pressure headache. So the first image is before and the second one is after the blood patch. And as you can appreciate, the caliber of the blood vessels before the blood patch is dilated, and it becomes normal once the blood patch is done and the patient's headache is completely resolved. So coming over to the presentation for post-dural puncture headache is classically fronto-occipital headache and is often associated with neck stiffness. Sometimes the pain will radiate to both the temples, and patient might have discomfort behind the eyes. The pain is usually more diffuse than localized. The headache typically has a very postural element to it, and the pain gets exacerbated by sitting or standing position and gets alleviated by lying flat. The postural feature of the headache is, the postural feature of the headache with the pain is the main differentiating feature from other kind of headaches such as subdural hematoma. Headache may be associated with other symptoms like nausea and vomiting, tinnitus, vertigo, or hearing loss, and sometimes there's visual disturbances such as diplopia and photophobia. If the CSF rate, the CSF production rate is faster, the CSF loss is faster than the production, this leads to further reduction in the intracranial pressure and more downward traction, and sometimes it can cause traction on the cranial nerves, leading to especially the sixth cranial nerve. So incidence of post-dural puncture headache is in the range of 1.5%, and more than half of these patients go on to develop post-dural puncture headache. The incidence of dural puncture is 1.5, and about more than half go on to develop post-dural puncture headache. If you look at more recent studies, the incidence has shown to be even higher, and something in the range of 76 to 85% of patients post-dural puncture develop headaches. Onset, 90% of headaches will occur within the first 3 days of the procedure, and about 2/3 of these usually occur within the first 48 hours. However, this headache can develop as late as up to 14 days after the procedure. And very rarely it can even present immediately postpartum. Duration, most of these headaches will resolve spontaneously within a week. even if left untreated. And in minority of the patients, it can become occasionally become chronic headaches. Diagnosis: the symptoms of postural headache and the history of dural puncture is usually sufficient to make a diagnosis of post-dural puncture headache. If in doubt, additional investigations such as MRI may be needed to confirm the clinical findings and rule out other serious causes of headache. The MRI scanning may demonstrate evidence of reduced CSF pressure, myelography, or thin sections of MRI, or can be used to locate the source of CSF leak as well. Sometimes Doppler ultrasound can be useful in revealing the high flow velocity in the cerebral vessels in these patients with PDPH. We must always remain cognizant of the fact that there are multiple other causes of headache in the postpartum women, and we should look at other differential diagnoses and consider them as well. Risk factor: the inadvertent dural puncture and post-dural puncture headaches are avoidable complications. Therefore, as anesthesiologists, we need to be familiar with the risk factors and prevention. For patients whose dura is violated intentionally, say after a spinal anesthetic or a combined spinal epidural, or even deliberate dural puncture techniques, the most important modifiable risk factor has to be to do with this needle selection. The smaller needles, say 24, 25 gauge, or pencil point needles like Whitaker and Sprout, have lower incidence of post-dural puncture headaches when compared to larger needles, 20 gauge, which have a cutting edge like Quincke's, where the incidence of headaches could be as high as 30 to 70%. The other risk factors which are associated with post-dural puncture headache is the gender. Pregnancy itself is a risk factor. Younger patients are more prone to these headaches, and history of prior headaches because of dural puncture. Now, the obstetric patients are considered high risk for post-dural puncture headache, and not surprisingly because of their sex, their younger age group, and also the widespread use of neuroaxial blocks in these patients. So we anesthesiologists have been active in attempting to reduce our incidence of post-spinal headaches by reducing the size of our spinal needles. Today we are using smaller needles. However, we have to be aware that the apprehension over the lack of rapid appearance of CSF through the needle when you're using a smaller gauge needle may result in multiple attempts in a haste. Therefore, CSF leak through perhaps multiple unrecognized dural holes can result in post-dural puncture headache after a apparently simple, uneventful spinal anesthetic. Apart from the size, the shape of the needles, the incidence is also inversely related to the experience of the anesthesiologist. We all notice an increased incidence in our PDPH rates around the time we have new residents rotating through our units. Another needle-related factor that results in reduced incidence of PDPH is the orientation of the bevel, which they say should be parallel to the long axis of the spine, so that we are not cutting through the dural fibers and we're just separating them, and once the needle is withdrawn, that hole will close. The evidence for this is weak. The epidurals can be inserted with both loss of resistance with saline or air technique. There's a lot of literature around that with pros and cons of both the techniques. There's some suggestion that using a continuous pressure on the syringe with saline may have an effect on moving the dura anteriorly as the needle approaches, thereby reducing the likelihood of dural puncture compared to the intermittent pressure technique with the air. In addition, inadvertent dural tap while using a loss of resistance with air may result in pneumocephalus, which could be another cause of headache. Once we have a dural puncture, unintentional, it is critical that in this event be recognized. These patients, at the least, be clearly informed about high risk of having a post-dural puncture headache, and they should be followed daily until discharge, or be called at home following discharge for about 48 hours or till the symptoms resolve. What additional measures can we adapt to reduce the risk of post-dural puncture headache after unintentional dural puncture? This has been studied, and however, due to the lack of conclusive benefits of such interventions, we should always weigh carefully against the risk. One of the things suggested is a stylet replacement before pulling the needle out. Replacing the stylet is a simple and effective means of lowering the incidence of post-dural puncture headache. Given its innocuous nature of this maneuver, there appears to be little reason why we should not be doing it. It does make sense to put the stylet back before you remove the needle. Limiting or avoiding pushing. So in an event of unintentional dural puncture, limiting the duration of the second stage of labor, usually by, say, 30 or 60 minutes, or avoiding pushing at that time, can reduce the risk of PDPH. Although if you look at the literature carefully, the evidence of this is, again, quite weak. And this is not a common practice in Canada. How about intrathecal catheters? This became popular a little while ago. Immediately placing a catheter when you get an unintentional dural puncture has an advantage of being able to readily provide spinal analgesia, as well as eliminate all the possibility of doing another accidental dural puncture in a challenging clinical scenario. However, the potential benefits of intrathecal catheter must be weighed against the readily appreciated risk, which is accidental use of these catheters or misuse, or even the risk of infection related to these catheters. The mechanism of benefit of intrathecal catheter is not very clearly understood, but it's believed to be because of reaction around the catheter or inflammation, which can cause the sealing and prevent further loss of CSF. There has been a meta-analysis which included 9 studies and which concluded that intrathecal catheter insertion following accidental dural puncture did not show any decrease in incidence of post-dural puncture headache. How about injecting saline? Again, there's limited evidence that indicates that if you inject intrathecal saline following an accidental dural puncture, this might be associated with a significant reduction of incidence of post-dural puncture headache. And the need for epidural blood patches may be decreased. This is thought to be by maintaining the CSF volume. However, the evidence is not strong, and we need to have further investigation into these before we make conclusive recommendations. Prophylactic epidural blood patches. Again, the systematic review published in the BJA showed that the role of therapeutic or prophylactic epidural blood patch for treating PDPH is inconclusive. When unintentional dural puncture occurs, there's several conservative therapies that are commonly used, such as hydration and bed rest. These methods are simple and do not have any serious side effects. However, the conclusive evidence is again lacking, particularly during the puerperium when you want these women to be up and about and ambulate to decrease their risk of DVTs and PEs. You don't want them to be tied to the bed. There has been a Cochrane review on this, which has again showed the evidence suggesting a routine bed rest after a dural puncture is not beneficial. And as also there's no evidence to support the benefit of prophylactic fluid supplementation after the post-dural puncture headache. What we do need to do is reassure these patients and use measures directed towards minimizing the symptoms, while we do not expect them to alter the natural course of the disease. However, it'll provide some relief to the patients. Other supportive management for symptom relief includes simple painkillers, non-steroidal anti-inflammatory drugs, or acetaminophen. Keeping yourself hydrated or avoiding dehydration is more useful than overhydration. Caffeinated drinks, again, has been popularly and continue to be used. Antiemetics and stool softeners should be prescribed when indicated. Abdominal binders have been advocated. Again, these are very uncomfortable and are very seldom used in modern day practice. Certain alternative measures like acupuncture or bilateral greater occipital nerve blocks have been described to provide symptomatic relief as temporizing measures before the epidural blood patches. There are several other prophylactic drugs that have been studied in their clinical effectiveness has not been established again. For example, epidural morphine or IV ACTH, which some studies have shown very promising effect in preventing PDPH after dural puncture. However, this is neither recommended nor routinely used because of limited evidence and the side effects. So, as we all know, epidural blood patches has emerged and remains a gold standard for treatment of post-dural puncture headache. The first reported blood patch was suggested by Dr. Comley in 1960. How does the blood patch work? The postulated mechanism for action for epidural blood patch involves sealing the dural puncture site. MRI studies have found that this epidural blood adheres to the thecal sac, resulting in a clot formation, and this clot can be stabilized or remain there for about 18 to 24 hours sometimes. The pain relief is often rapid after the application of blood patches, and this we have noted in our day-to-day clinical practice as well. Although we don't expect the CSF volume to be restored immediately, how do these patients get immediate relief from epidural blood patch? There is a hypothesis that the epidural injection of blood will increase the CSF pressure around the lumbar region, which will subsequently restore the intracranial CSF pressure and resulting in reflex cerebral vasoconstriction. And this possibly leads to relief of headache in the immediate period. There's also some observational studies which have suggested that if you do blood patches too early in the first 24 to 48 hours, they might not be as effective. However, again, this evidence has to be weighed very, very critically because early onset of post-dural puncture headache likely to be more severe, and there could be a selection bias possibly, as well as if the epidural blood patches are performed too early, the clot degeneration may occur, or because of higher CSF flow, there might be displacement of the clot. So again, the evidence is there, and most of us prefer to wait the first 24 to 48 hours after the symptoms, managing patients conservatively before we do the blood patches. But however, this should be determined by the severity of the patient's symptoms. The optimal value or volume of the blood to be used has been studied extensively, ranging from 5 to 30 cc's. Peach et al. Had randomized 121 patients and studied 3 different volumes, 5, 20, and 30 cc's of autologous blood in patients, and they found very similar efficacy of epidural blood patch with the 3 volumes. However, subsequently, we've seen some studies which have compared 20 to 30 cc's, and they have shown that 30 cc's did not show any further benefit from the 20 cc's. So anything in the range of 15 to 20, 25 cc's would be optimal. So in conclusion, I would like to say that post-dural puncture headache is an entirely iatrogenic complication and of our neuroaxial techniques. The most effective method of decreasing the incidence to develop technique is to minimize the dural hole formation during the epidural spinals, and that to prevent any inadvertent dural puncture during the epidural blocks. We need to be better aware of the risk factors related with the post-dural puncture headache, and it is important for clinicians to be very vigilant when performing these procedures. Reviewing the literature, we know that although there are various prophylactic interventions after unintentional dural puncture, which have been studied extensively and suggest some benefit to preventing either post-dural puncture headaches or the need for epidural blood patches. But we are also aware that the evidence is insufficient and there is further research needed in this area. Thank you.
That was a wonderful lecture. Thank you, ma'am. I'm sure no anesthesiologist will have any more headache due to PDPH here after the lecture. Now we will start for question answer session. Over to you, Parag.
My first question is to Dr. Sunanda Gupta, ma'am. Ma'am, can you hear me?
Yes, I can hear you.
Yeah, the question is, ma'am, do you think socioeconomic status is the biggest hurdle in India in implementing ERAS protocol?
Thank you very much, Doctor. That's a very relevant question. The low socioeconomic status. There are many issues here which I talked about, which are going to prove a barrier for implementation of your ERAS protocol. Now, when a low socioeconomic status person, if she belongs to a rural area and she is a farmer by profession, when she goes back, travels all the way, after 2 days, we discharge her in the early ERAS protocol. She goes back to her village. Now, coming back 100 kilometers from that village to the tertiary care center has logistical implications. And the most important thing is, even if she complains of pain, she complains of her symptoms, because of paucity of medical aid, medical ambulances which are available to carry her to that tertiary center, her health issues will be overlooked. So yes, a low socioeconomic status is definitely a barrier in our country. Unless we provide exemplary healthcare services, primary health centers will not be able to implement it in a
Next question. Is it possible to implement ERAS protocol for emergency cesarean section and how to implement it?
Ma'am, please unmute yourself. Thank you, ma'am.
Yeah, okay. So I think you heard the first answer.
Yes, ma'am. The second question, ma'am. Is it possible to implement ERAS protocol for emergency cesarean section and how to implement it?
Okay. Now, in the ERAS protocol, there are two pathways. One is for the elective cesarean section, which starts from a day prior, while in the emergency situation, it starts just about 30 to 60 minutes before. So how to implement it? Basically, the carbohydrate drink, which we schedule for 2 hours before, cannot be given. So we need to skip that. And the preoperative fluids that we give, that mostly we do not give. It is only co-loading. And we have to be careful that it has to be 10 ml per kg. The counseling, again, which we need to do preoperatively, we are not able to do it in a very effective manner. But maybe during the regional anesthesia, a little bit of counseling during that period is very effective. Now, the second important thing is hypotension. Being proactive, preventing hypotension, trying to keep the blood pressures within 90% of the baseline or 100% of the baseline with your phenylephrine doses, or ephedrine if she has, all the contraindications which earlier my speakers have discussed about. Trying to keep it at baseline with vasopressors, that's important. Hypothermia, if you have got warmers in your operation theater, that would go a long way in helping an ERAS protocol. An antibiotic prophylaxis can be given, a PONV prophylaxis we all give preoperatively, and a multimodal analgesia. That again is very important in the intraoperative period. As soon as the baby is delivered, you can give your dose of analgesic. And maternal bonding and delayed cord clamping. All these can be implemented in the emergency patient. Now, post-operatively, these patients, you can continue the ERAS protocols. Like what we do is ask the patient to start chewing gum. That itself helps in these patients. And after 2 hours, giving the first liquid diet, and then continuing with ambulation, making her get down from the bed, sitting on the chair, and then waiting for her to ambulate in the next 6 hours or so, and early removal of the urinary catheter. Now, all these can be done if she does not have any comorbid conditions. That is really very important. And the most important thing is scheduled doses of your analgesics, both acetaminophen and your NSAID. That is going to help these patients in a big way. We do not normally implement the ERAS protocol in general anesthesia patients because they are at-risk patients mostly. So we have not used them. But if you are using ERAS protocols in your general anesthesia patients, then a multimodal technique, which could involve a tap block along with your analgesics.
Ma'am, last question for you. How important is the communication between surgeon and anesthesiologist for implementing the ERAS? Because most of the times we face that problem. Surgeon doesn't instruct the patient about the guidelines.
Very true. Without the surgeon's cooperation, you cannot start your labor epidural analgesia, nor can you start your ERAS protocol. So we are very dependent in India on a very good cooperation with our surgeon. So
even in our situation, in our department, the ERAS protocol, we had to motivate our obstetrician that we will start research in a joint manner with the neonatologist, with the obstetrician, and the anesthesiologist. So all three of us clubbed together. We had meetings for, 3 meetings we had. We looked at all the protocols, how many are going to be implemented. And midway, the neonatologist was transferred from our institute, and the neonatologist who came in was just against that protocol because he wanted to carry each and every neonate who was delivered by cesarean section to the neonatal ICU. So there were so many barriers trying to implement this protocol, but then we had to leave that protocol, which involved neonatologists. There were 9 elements to that protocol, so we had to leave that. But once the results started coming in, believe me, all the obstetricians were very happy, and they all started implementing the protocol. So in toto, you do not have to implement it. Start implementing with 5 or 6 elements and start looking at the results, and then the other protocols can be implemented very coolly with them.
Thank you, ma'am. Thank you very much.
Thank you, ma'am. We have few questions for Dr. Vasudha Misra, ma'am. Ma'am, can you hear us?
Yes, I can. Thank you.
Ma'am, the lecture was very elaborative. But we just have only one question about it. Is whether any queries about sphenopalatine block or PDPH?
Okay. Before I go ahead to answer that question, I would like to extend a big thank you to Dr. Deshmukh and all the other organizers for inviting me to be a part of the CME. It was very well conducted. Thank you all. Coming back to your question about sphenopalatine block, yes, there has been evidence, but we have to bear in mind this is not a cure for post-dural puncture headache. All it does is provide some symptomatic relief to the patient. In my clinical experience, the benefit of this is very, very short. Even when I've used longer acting bupivacaine for the blocks have lasted anything between 2 to 4 hours, and the patient's back in pain again. So yes, it is a temporizing measure to provide some symptom relief while you're waiting for a blood patch or when there is a contraindication to doing blood patches.
Ma'am, next question. Any side effect of epidural blood patch?
So that's another good question. Again, it's another epidural, so the risk remains the same. Pretty much all the risk of having the epidural, which includes a dural puncture. And that is the reason we have to be very careful in deciding on this treatment modality. We don't usually rush in to do a blood patch as soon as we hear about a headache. So risk of infection or hematoma or another dural puncture, as well as if the patient has other signs of sepsis, you want to rule that out before going ahead and doing a blood patch.
Ma'am, is there any role of gabapentin in PDPH?
That's been studied as well. Like with all the other drugs I had mentioned, the evidence is inconclusive about gabapentins for post-dural puncture headache. So it's not being used clinically right now.
Ma'am, in your lecture, you have commented about the orientation of a bevel. Ma'am, during epidural, orientation of bevel, we do know that it will mind. But in subarachnoid, that is PDPH, we are piercing the arachnoid matter. So really, the orientation of bevel will affect in PDPH?
Again, that's been showed in some of the experimental studies where they have done images and looked at how the dura separates with the placement of the bevel. Like I said in my talk, the evidence is not great. Some studies have shown that they oppose better once the needle is withdrawn if the bevel is in one direction, which they postulate is because it's separating the dural fibers as opposed to cutting them. But again, in our clinical practice, we know that we don't see a difference with that.
That's it, ma'am. Thank you. Thank you so much, ma'am, for the question answers.
You're welcome. Thank you.
Thank you, Dr. Sunanda Gupta ma'am, Dr. Vasudha Mishra ma'am, for such excellent and informative deliberations and answering all the questions. In spite of prior other commitments, travel plans, and being in different time zones, you made it for us today. We appreciate and thank you for your presence. We, the Department of Anaesthesiology, Datta Meghe Medical College, and Indian Society of Anaesthesiologists, Nagpur City branch, have a small token of gratitude and appreciation for you, the e-mementos. Please accept it, Dr. Sunanda Gupta madam and Dr. Vasudha Mishra ma'am, with our sincere thanks.
Thank you.
We acknowledge the
Thank
contribution. Thank you, ma'am. We acknowledge the contribution of Themis Medicare for the help they provided for the conduct of the CME. Thank you. I now invite Dr. Deepak Madankar, sir, Honorary Secretary, ISA, Nagpur City Branch, to propose the formal vote of thanks. Over to you, Deepak, sir.
Thank you, Anjali. That was an excellent last third session. So before going with formal vote of thanks, can we show mementos for our chairpersons today? For the last session, Dr. Anjali Borkar. Dr. Parag and Dr. Kirti. Thank you, chairpersons. It was an excellently conducted session. Esteemed faculties for today's program, all the esteemed chairpersons, Professor and Head, Department of Anaesthesiology, DMMC, Dr. Pratibha Deshmukh ma'am, GC member MSc ISA, Dr. Sheetal Dalal, and GC member and President, Dr. Saurabh Berde, Advisory Board member MSc ISA, Dr. Anjali Bhure, respected seniors and dear friends. With great pleasure and privilege, I propose vote of thanks for today's program. At the outset, I would like to thank all the faculties for today's CME, Dr. Gauri Sankhe, Dr. Mrinal Balki, Dr. Radha Kunte, Dr. Ivan, Dr. Fabricio, Dr. Sunanda Gupta ma'am, Dr. Vasudha Mishra for their excellent and enlightening talks for all of us. I'm sure we all will be immensely benefited by today's program. I'm grateful to Dr. Pratibha Deshmukh ma'am, Professor and Head, Department of Anaesthesiology, DMMC, and her team, Dr. Anjali, Dr. Parag, and others for being partner in organization of today's program. Thank you, Pratibha ma'am, for all the great efforts you took for today's CME. I'm grateful to all the chairpersons for today's CME, Dr. Manisha Shembekar, Dr. Hemangi Abhyankar, Dr. Archana Deshpande, Dr. Dipali Mandlik, Dr. Anjali Borkar, Dr. Parag Sabre, and Dr. Kirti for consenting to be chairpersons for today's CME and conducting today's sessions in an excellent way, and for taking all the efforts to conduct these sessions. I'm grateful to Dr. Narendra Tamne sir, MMC Observer, for today's program, for his gracious presence. I'm thankful to Mr. Vaishnav of Themis Pharma and Mr. Nishant Berde for their help and support for today's program. Without delegates and attendees, no program can be success. So I'm thankful to all those who joined this on Zoom as well as the YouTube platform and actively participated to make this program a great success. I'm thankful to the team of ISA NCB 2021 for being a support as always. Thank you. Thank you all.
Thank you, sir.
Thank you. So, thank you all faculties. We'll conclude here. Dr. Saurabh? Pratibha Deshmukh, ma'am?
Yes, please conclude.
Okay, thank you. Thank you all.
Thank you.
Thank you all. Thank you
Thank
all.
you all.
Thank you, ma'am. Thank you very